Oh yeah, the subcommittees are subject to open.
Good afternoon, everyone. Welcome. This is the House Appropriations Committee Health and Social Services Subcommittee. I am Vice Chair Dana Jones, and we have, as we approach crossover, we all have to be in 4 different places at once. So some of our members will be joining us shortly, but let's start with MDH's Health Regulatory Commission. Our analyst, Ann Braun, will come up. Wonderful. Begin when you are ready.
Great. Thank you, Madam Vice Chair and members of the committee. Today, I'm presenting the budget analysis for the Health Regulatory Commissions. This includes the Maryland Healthcare Commission, the Health Services Cost Review Commission, the Community Health Resources Commission, and the Prescription Drug Affordability Board. The fiscal 27 allowance increases by $7 million to $366 million across these offices, almost entirely in special funds. Moving to fiscal 2026, there are 2 legislative additions that we've highlighted. $350,000 was added to the HSCRC budget to pass through funding through CRISP for services from Dr. First. This funding has been spent in fiscal 26. The other legislative addition was a grant for the Maryland Patient Safety Center. Last year's BRFA eliminated the annual $1 million mandate for the center, and this add provided $200,000 that has also been fully spent in fiscal 2026. There is one proposed deficiency, and that provides $6.3 million under MHCC to account for additional revenue from the vehicle registration surcharge. Legislation from 2024 increased the surcharge and then required increased distributions to the Shock Trauma Center and the Maryland Trauma Physician Services Fund, and so the deficiency is split between those 2 uses. The Shock Trauma Center used to receive an annual operating grant through the MEMSOF Special Fund. That was planned to end in fiscal 2025, but then the reported actual spending included a $3.7 million MEMSOF distribution. MHCC and DBM acknowledged this was an overpayment since the center now receives direct vehicle surcharge distributions. And so MHCC is asked to discuss the timeline for recovering the $3.7 million overpayment. Turning to the fiscal 27 allowance, Exhibit 1 shows the components of the fiscal 27 budget. You'll see that the largest component is $130 million for the uncompensated care fund, and that accounts for about 1/3 of the budget. That is funding that's distributed by HSCRC to hospitals for care that they don't receive compensation for, so like charity care, financial assistance, and bad debt. I'll also highlight that just over $50 million in operating expenses are supported with user fees. So the bar on the right shows that HSCRC accounts for a little over half of those user fees. As I had mentioned in the Medicaid analysis, HSCRC collects hospital assessments, including significant amounts that support Medicaid expenses, in addition to the fees it collects to support its own operating expenses. And so considering the increased federal scrutiny and the OBA implementation of a provision that affects provider taxes, HSCRC is asked to comment on how hospital assessments may change, especially as it relates to certain requirements for taxes to be uniform and broad-based. Exhibit 2 on page 5 and continuing on to page 7 shows the proposed budget changes from fiscal 26 to 27. The largest driver of spending growth is a $10 million increase for the Consortium on Coordinated Community Supports. This is after accounting for a $20 million contingent reduction that is contingent on the BRFA provision reducing the funding mandate. Personnel costs also grow, in part due to the transfer of 4 positions into the commissions, mainly for HSCRC. There are 2 budget discussions that start on page 7. The first discusses a special fund reduction of $1 million. That's contingent on a proposed BRFA provision that waives the requirement that $8 million in cigarette restitution fund support Community Health Resource Commission's grants. This would be waived in fiscal 2027 only, and the CRF support would be transferred to Medicaid to provide general fund relief. The fiscal 25 closing fund balance was just over $2 million under the MCHRC fund, and so DLS recommends reducing CRF support by another $1 million to provide $2 million in general fund relief under Medicaid. This action would be a language amendment under Medicaid and will be presented as part of the decision process. Also note there's a technical recommendation to amend the contingent language to more closely align with the BRFA provision. The second budget discussion relates to uncompensated care. If you turn to Exhibit 3, this shows trends in uncompensated care since 2010. It's shown as a percent of patient revenue. The main takeaway here is that uncompensated care decreased significantly following ACA implementation. You can see that in 2015 and on. And with recent federal actions like OBA provisions that will lead to Medicaid disenrollments and changes to the premium tax credits available through the exchange, there's expected to be increases in uninsured and underinsured Marylanders, resulting in more uncompensated care. Moving to the key observation section that begins on the bottom of page 9. The first item covers Maryland's recent activities related to the end of the total cost of care model on January 1st and the new AHEAD model. These are agreements with CMS that set the parameters for Maryland's hospital rate setting system, and the plans seek to control growth in healthcare costs and improve population health. To cover the total cost of care model, Maryland met every performance benchmark for 2024, and the results are shown in Appendix 2. To discuss the AHEAD model, in the past year, there was a lot of work done by HSCRC and MDH to renegotiate the AHEAD model with CMS, and an amended agreement was signed on November 12th. Under the new agreement, HSCRC will continue to set global budget revenues and have rate-setting authority for commercial payers, Medicare Advantage, and Medicaid. But then following a 3-year transition period, the federal government will take over rate-setting authority for fee-for-service Medicare. Maryland's required fee-for-service Medicare savings target is $460 million by Plan Year 7 in 2032. And there are cumulative cost growth requirements for Medicaid and Medicare Advantage of $870 million over the same period. The agreement still includes targets for primary care investments and quality and population health targets. But one new component is that Maryland must select at least one healthcare initiative related to consumer choice and one related to competition, and that's from the list of options shown on pages 10 and 11. And then to address issues related to AHEAD model implementation, the governor established a multi-agency regulatory working group. That group released a work plan in October and has made recommendations related to cost shifting and Medicare Advantage policies. One initial task for the group will be recommending which choice and competition initiative the state should select. And then one of the policy recommendations made by the working group and approved by the governor is to spread the state's required cost savings across multiple payers by using a cost shifting proposal to increase commercial hospital rates by $87 million annually from 2028 through 2032. HSCRC is still determining how that rate increase would be applied. Moving to a discussion of the fiscal 26 budget bill had language that restricted funds pending a report from HSCRC on efforts to align incentives between Medicare Advantage plans and hospitals under the AHEAD model. HSCRC submitted this report in December and included the working group's proposal for MA market stabilization. Page 12 summarizes this report, including past efforts to distribute funding to MA plans to facilitate access and partnerships with hospitals. Last year, HSCRC considered an alignment program to tie population health improvements to financial assistance for MA plans through differential hospital rates, but that initiative is not moving forward. Instead, the working group made a recommendation to provide financial assistance through reduced hospital costs to MA plans, specifically plans that mostly serve beneficiaries in Maryland, enroll a certain share of or number of their beneficiaries from low-income counties, and meet quality requirements by 2028. Based on HSCRC's response, DLS determined the report to be in compliance with the budget language and recommends the release of withheld special funds, and will process a letter if no objections are raised by the committee at this budget hearing. The rest of this key observation covers primary care initiatives under the AHEAD model. This includes the continuation of the Maryland Primary Care Program through calendar 2028. At that time, CMS will evaluate the program and decide whether it should be extended. There are also new initiatives to offer incentives for advanced primary care. This includes a new Medicaid path and a quality improvement path. And then legislation from last year also established the Population Health Improvement Fund. That is supported with hospital assessments and will be used to reduce the incidence of chronic disease. To continue monitoring these initiatives, DLS recommends narrative that requests a report from MDH and HSCRC, including an evaluation of the Maryland Primary Care Program over the entire total cost of care performance period now that that model has ended. Moving to the second key observation, this discusses the consortium, and it begins on page 15. The consortium was created as part of the blueprint to meet student behavioral health needs. If you turn to Exhibit 4, this shows current mandated funding levels, including the proposed reduction in this year's BRFA. That would reduce the mandate by $20 million on an ongoing basis beginning in fiscal 27. Exhibit 5 on page 19 shows the consortium grants by local jurisdiction. This shows the initial announcement of $99 million in grants awarded in fiscal 2026, but this was later updated to $97 million in total awards. There are 3 types of grants that, as there can be community supports partnership grants to a local behavioral health authority, a local health department, or a local management board, and that would be to oversee the funding for services. There can also be planning grants for counties that are starting up their community supports partnerships, and there can be grants made directly to service providers. Appendix 3 shows this funding detailed by grant type. When comparing each jurisdiction's share of consortium funding to their share of students who are eligible for free and reduced price meals, these measures generally align, but there are a few counties that make up a larger share of the free and reduced price meals enrollment, but receive a smaller share of consortium grants. Considering those discrepancies, MCHRC is asked to discuss how the grant-making process considers financial need and social determinants of health when deciding the county allocations for the consortium grants. For the next round of grants in fiscal 2027, an RFP was issued in December, and the consortium expects to announce grant awards this spring. I'll note that the consortium is estimated to have $16 million in remaining unspent funds at the end of fiscal 2026, but expects that the funds will revert to the Blueprint Fund at closeout. And so with the BRFA provision, that would allow for $80 million in grants for fiscal 2027. The final key observation discusses the Prescription Drug Affordability Board. The board is authorized to conduct cost reviews and establish upper payment limits through regulation for drugs purchased by or on behalf of a unit of state or local government, including employee plans and Medicaid. The list on page 21 shows requirements for drugs that the board can identify for cost review. And the board first identified 8 prescription drugs that met these requirements, but then narrowed that list down to 6 drugs. Staff members have presented findings and policy recommendations from the cost review studies for 4 of those drugs, the 4 that treat diabetes. The studies for Farxiga and Jardiance were presented in July, and then studies for Ozempic and Trulicity were presented in November. The cost review studies for the final 2 drugs that treat autoimmune diseases are expected to be presented early this year. All 4 drugs presented were found to create affordability challenges, and the board recommended starting the process to set upper payment limits for Farxiga and Jardiance. And the board also recommended considering non-upper payment limit options. The board is creating a methodology for upper payment limits for Farxiga and Jardiance, and has indicated that the board's also trying to streamline this process to set upper payment limits. The board is asked to discuss the timeline for implementing these upper payment limits and other recommendations for Farxiga and Jardiance, and how it would streamline the upper payment limit process. The board also included recommendations in its annual report that included prescription drug price transparency. This is also an option for choice initiatives under AHEAD, and so the board is asked to discuss if it's collaborating with the working group on AHEAD to consider advancing this as one of the state's initiatives. Recommended actions are shown on page 23, but I've presented both throughout this presentation, and so with that, I'll conclude. I'm happy to answer any questions.
Thank you so much. To our members, does anyone have a question for DLS? Wonderful. Thank you so much. All right, so next we will call down Douglas Jacobs, Executive Director of MHCC. And if you would like, I see that you have some guests potentially here with you. I see Dr. Scalea, of course, James Gannon, Justin Graves, and Kyle Remick. Or how do you want to do this, sir?
I'm open to however
Okay.
you'd like to do it.
Just call all the executive directors of the commissions.
Okay, they did, okay. We're just going to do all the executive directors of the commissions then. So Mark Luckner, Douglas Jacob, and Andrew York, along with Jonathan Crum.
I apologize. I joined late. Good to see you all. And Madam Vice Chair actually had a really brilliant plan that I completely stepped on, and I did not mean to do that. So forgive me. I'm going to ask, if it's okay, we need one of you to please sit back, and we'll call. We'll just go to. Please follow Vice Chair Jones's advice and not mine. Thank you.
Let me put on my microphone. So we're going to be careful to time. So should we go to Douglas Jacobs, Executive Director of MHCC? And I see that you have a few folks here that might have time constraints, as I understand. So Dr. Scalea, James Gannon with LifeBridge, Justin Graves with STC, and Kyle Remick with the trauma. With TraumaNet. So, Mr. Jacobs, when you're ready, go ahead.
Good afternoon, Chair, Vice Chair, members of the committee. My name is Doug Jacobs. I'm the Executive Director of the Maryland Healthcare Commission, MHCC, and also a practicing primary care doc. First, MHCC thanks DLS for their excellent summary, and all of you for the work that we've done together over the years. Just really quickly, I wanted to set the stage with just a reminder of what MHCC is and does, and we'll go into our strategic vision going forward, because this is my first budget committee meeting, and I appreciate it, and then also respond to the question that was posed by DLS. So MHCC is a 15-member independent regulatory commission that works to improve quality, control costs, and expand access to care through data, public reporting, health planning, and regulation. And so some of the areas that we oversee the state's all-payer claims database. That's the repository of all the claims information. And we do several reports for the legislature in analyzing potential costs of new mandated studies and other studies as well. We designate and oversee CRISP, the state's health data utility, and regulate health information exchange and electronic health networks. We operate a consumer-facing quality website, Maryland Healthcare Quality, to make a lot of the information available to consumers so that they know where to go to for their care. And we also have specific health planning functions, so certificate of need that many of you might be familiar with, the certificates of ongoing performance related to cardiac care, and recently we've started overseeing the mergers and acquisitions of skilled nursing facilities in particular. And as we move forward in partnership with other state agencies, we're helping to set primary care investment targets, do workforce strategy and post-acute care strategy as part of the AHEAD model, and are also partner to the Maryland Department of Health related to the Rural Health Transformation Program. And as you'll hear from the folks sitting next to me in a little bit, we oversee the Physician Services Trauma Fund in the state. So with regards to our strategy going forward, I'm separating into 3 policy buckets and 1 operations bucket that supports all of those policy buckets. So first is access. We're focused on strengthening primary care, addressing those workforce challenges, and improving coverage and utilization policies. And that includes what I mentioned in the AHEAD model, and also working with state partners on telehealth policy, electronic use of prior authorization, and data integration to support eligibility coverage as part of our work to oversee CRISP. Second, reducing disparities. We're using data and health planning tools to advance health equity. We're identifying high-performing providers serving underserved communities, and working to improve the connections between medical and social services, and updating certificate of need criteria to really focus on new entrants into underserved areas and improving competition. And third is value. And so this is focused on quality, safety, and competition in the healthcare system, but also quality improvements in long-term care, how we actually can look at our quality data and improve the use of it, and also strengthening transparency around those mergers and acquisitions, changes in ownership that are increasingly occurring in the state. And so on an operations side, we're looking to support those policy buckets. We're looking at our data infrastructure and how we can integrate them. And also launching a redesigned website to make it more accessible and building staff capacity. So through all this, we look forward to our partnership with the General Assembly, the Governor's Office, and stakeholders. And so I wanted to briefly mention that response to the DLS question in particular. You might remember the DLS question was the timeline for recovering the $3.7 million that was distributed to the Shock Trauma Center in error in fiscal year 2025. And so this is now taken care of completely as February 2025. MHCC, the Comptroller's Office, and MVA coordinated to fully recover the $3.7 million. And we ensured all documentation is now accurate and reflects the correction, and we've reconciled all payments. So thank you, and happy to answer any questions.
Thank you so much. This is not the normal way we do panels. Here, usually we have all of the regulatory commissions together, and then we do questions from our members to all of the executive directors, and then we take panelists. But because we know that a number of you here, in particular Dr. Scalea, you need to leave to run our trauma network, we wanted to give you all an opportunity to testify, and then we will do questions for this panel at that point. Thank you. Dr. Scalea, you can go ahead and do your testimony.
I'm okay now? Okay. Madam Chairman, Vice Chairman, and committee members, my name's Tom Scalea. I know virtually all of you, I think. I'm incognito today since I'm not dressed in pink, but it's really me. I've submitted my full testimony for your review. Thank you for the opportunity to speak, and thank you for your continued partnership in sustaining Maryland's world-renowned trauma system. The Shock Trauma Center is the state's primary adult resource center, PARC, and it's a core element of Maryland's integrated emergency medical services system. It's important to remember that we have something in Maryland that everybody else wishes they have, and they don't. The system has never been replicated in well over 60 years. Shock Trauma is the only freestanding trauma hospital in the United States, and we care for 6,200, 6,500, depending on the year, patients each year with a 96 or 97% survival rate. So contemplate the number of lives saved that means. Just over 25% come from Baltimore City, our state's largest city. 30% of our admissions, over 2,000, are transfers, so they go to another hospital and then come to us when they're found to have something that needs to be downtown. 700 or more of those are from other trauma centers in the state. We function as a backstop to the trauma system. We maintain 24/7 immediate and dedicated readiness, and that's dedicated meaning when we are working, that is all we do. We're not covering anything else. Thanks to the dedicated funding that you have provided, we have made significant and measurable improvements that benefit the entire state. First and foremost, we can fully staff our operating rooms, new from several years ago. All 8 ORs have reliable, consistent staffing, nursing, anesthesia, and surgery. This has had a tremendous ripple effect on the downstream movement of our patients. We actually have enough room to take care of everything we want to on every day. This has been a godsend, really. These efforts have enabled us to accommodate substantially larger numbers of interhospital transfers. We've reduced lost interhospital transfers by over 2/3. That means the people that need shock trauma get to come, and they get to come immediately now. We keep our doors open for everyone. The state's benchmark for capacity or diversion is 5% of the time. We never go on complete diversion. Capacity is what we call partial diversion, and we've reduced this to almost zero. When we do, it's because we get 6, 7, 8 patients at once, and we just need an hour to kind of sort everybody out, and we immediately reopen. Why does this matter to Marylanders? Trauma is a disease that has no boundaries. I don't care your sex, your ethnicity, you're rich, you're poor, everybody gets hurt. And this support has allowed us to become the shock trauma center that we really want to be. We have the ability to say yes. For over 60 years, the legislature, the Shock Trauma Center, and the Maryland Trauma System have had a very, very special relationship. And I thank you from the bottom of my heart for all of that. You have invested in us, and I believe we have reinvested in the state of Maryland. This support enhances readiness and efficiency. It's streamlined access. It has very clearly increased survival. Shock trauma is dedicated to the care of badly injured patients, and we will always be ready when you need us. Thank you for your time and your ongoing commitment to trauma care in Maryland, and I will be happy to do my best to answer questions.
Committee members, thank you for this opportunity to speak today. My name is James Gannon. I'm the Trauma Program Manager at Sinai Hospital in Baltimore City. Trauma centers must maintain readiness 24/7, 365 days a year, not for convenience, but because injury does not wait. At Sinai alone, in FY22, just to maintain required specialty readiness, it exceeded $21.5 million. These are fixed, non-negotiable costs. At the same time, recently, we're seeing a growing percentage of undocumented and uncompensated trauma care. Trauma centers are required to treat every injured patient, regardless of insurance or ability to pay. As the number of uninsured and underinsured patients increase, reimbursement often falls short of the cost of providing highly specialized trauma care. The Trauma Physician Services Fund was created because trauma readiness is uniquely expensive. A state commission in 2023 confirmed that these costs have risen dramatically and that previous funding mechanisms were not keeping pace. Investing in trauma care saves lives and saves money. A peer-reviewed study published in 2024 showed that reducing statewide trauma mortality preserved an estimated $4.3 billion in lifetime personal income and $508 million in tax revenue, illustrating that trauma system funding is an economic return, not just an expense. In addition to a national data demonstrating economic return, published research examining statewide trauma systems, including work that I co-authored, reinforces that coordinated trauma care networks with sustained funding are associated with measurable improvements in survival and system performance. These systems require stable funding to function. At Sinai, we're using grant funds to prevent injury before it happens. We're addressing elderly falls, which cost over $50 billion annually nationally, and distributing gun safes and gun locks to prevent pediatric firearm injuries, such as 6-year-old Lachelle Lee IV in Montgomery County and 9-year-old Ava Sewell in Baltimore City. We are also strengthening trauma quality and workforce training, and reporting measurable outcomes with the MHCC to demonstrate the real impact of these investments.
Sir, thank you so much for
Thank
your
you.
testimony. Do you want to
Yeah.
finish your thought?
Well, it was just, if the community allows funds to be redirected or reduced, then we do risk weakening Maryland's trauma safety net. Really appreciate your time.
Thank you so much. Next.
Madam Chair Shetty. My name is Justin Graves. I'm the director of the trauma programs at the University of Maryland Trauma Center. And I want to spend a little time talking a little bit about our education, our outreach and prevention efforts that we are so fortunate to be able to do because of the funding. Last year alone, our programs reached more than 22,000 Marylanders across 17 counties. Stop the Bleed is a good example. In FY25, we trained over 10,000 Marylanders to control life-threatening bleeding, including thousands of students and nearly 1,000 school staff. Working with our partners in TraumaNet and the Maryland State Department of Education, we've been advancing efforts to incorporate Stop the Bleed training into the health curriculum for all Marylanders. And we learned last week that this was approved by the Board of Ed, so that will go into effect in the 27-28 school year. Violence prevention efforts remain another critical priority. Last year, 643 victims of violence were screened at the bedside, and 57% of those chose to engage in wraparound services designed to reduce the risk of retaliation and re-injury. In October, we also opened Maryland's first trauma recovery clinic, bringing medical care, mental health services, legal support, case management, all together in one place for survivors. We're also working upstream through our SMARTER program, Saving Maryland's At-Risk Teens, which partners with the Department of Juvenile Services, Baltimore City Schools, to engage young people after a first gun-related offense. Finally, falls remain the single largest driver of trauma admissions, accounting for 43% of our patients. Through our Fall Recovery and Prevention Program, we are working with older adults across Maryland to prevent repeat injuries and help them remain safe and independent. These programs demonstrate the impact of the legislature's investment, not only treating trauma, but preventing it. So I want to thank you for your continued support and allowing me to testify today.
Thank you so much for your testimony. Now we're going to turn to you colleagues for questions for MHCC. Are you part of the trauma group? Sure. Yeah, no problem. Okay. Welcome. We're happy to have you here.
Thanks, and I'll be brief. Everyone said a lot of great things already. So I'm Kyle Remick. I'm a trauma surgeon in Western Maryland. I am the chair of the Maryland Trauma Center Network, better known as TraumaNet right now, so I'm giving my testimony from TraumaNet. We know, as Dr. Scalia and the others said, that our trauma center and shock trauma center is one of the best in the country and the world. Our trauma system is one of the best in the country and the world, and of course that costs money. In addition to what Dr. Scalia talked about at Shock Trauma Center, the other trauma centers also in the state, which, by the way, the whole state sees about 34,000 trauma patients a year. So there are a lot of trauma patients that get their full care in the periphery of the state, not in Baltimore, or in Baltimore other than shock trauma. And there are those that we rely on Shock Trauma Center for as the backstop, as he said. So other than what Shock Trauma Center is getting, there's obviously ever-increasing volumes. There's updates in equipment that's needed. There's specialty care centers that are pediatric burn and hand trauma that have been developed in the last decade, and rising costs of on-call physician fees, especially at some of our outlying centers like the level 3 I'm at. It costs money to keep neurosurgeons and orthopedic surgeons on call. And then, of course, other uncompensated care costs. So there's quite a bit of information in the testimony that TraumaNet submitted in the written form, which I encourage you to just at least skim very quickly. But to conclude, we have a saying in trauma that is, where you are injured should not determine whether you live. And of course, a little bit of an extreme example to make everyone, to think a little bit, but that really does embody our thought that we need to have equitable trauma care across the state, whether you're in Baltimore, northeast, south, or west of Maryland, and we want to continue Maryland being known for the best trauma care in the world. Thank you.
Thank you so much. Okay, do you have your mic lit up? I can't see. Delegate Ruff? No. Sorry? Okay, I apologize. Sorry. Questions from the subcommittee for the trauma panel as well as MHCC? I think Delegate Jones, you have a couple on MHCC. There we go. All right, one moment, please.
As we go out of this is our very last budget hearing, and we're throwing all the rules up into the air so sorry about that. I just wanted to go into vacancies, please. On page 9 of the DLS analysis here, notes HRC reported 10 vacancies as of December 2025. Can you describe any recruiting efforts, hiring efforts, or efforts HRC has taken to address the issue of filling these vacancy positions?
I'm sorry. I think for MHCC, that is not our vacancies, but maybe I'm not seeing it right. Is it?
No. Health regulatory.
Oh, I think that's combined maybe across all of the health regulatory commissions.
Oh,
Because
so you have 2 vacancies?
Yes, yeah.
And 9 are over all of the vacancies. So for your 2 vacancies, can you describe the recruiting efforts, or where are you on filling those?
Yeah, so I believe that we've filled at least one of those vacancies and just submitted 2 other pins for recruitment and are getting applications now. But I can double check on those specific vacancies to make sure have those pins accurately.
That would be great. If you could follow up with the subcommittee, please.
Yep.
Sooner rather than later,
Yeah.
as decisions and such. That would be great.
Yep.
And then Maryland Patient Safety Center. I'd like to talk about that for a second.
Sure.
To discuss the Maryland Patient Safety Center, as discussed on page 2 of the DLS analysis. There are no appropriated funds for FY27 for the Patient Safety Center. It's my understanding that they do a lot of important work for healthcare quality. Can you comment on how they have previously leveraged their funding?
Yeah, so the Maryland Patient Safety Center gives us a report roughly every 6 months about their activities. And last year, the General Assembly approved $200,000, and the year before it was $1 million. They have activities more recently, such as quality improvement, looking at safety across a lot of the hospitals, looking at infection prevention and falls, and they also had an initiative related to workplace safety recently. And so MHCC designates the Maryland Patient Safety Center and would be open for additional thoughts from the General Assembly as you see fit.
Okay, thank you so much.
Yep.
See, I can't see if your mic is on, Delegate Stanko. It is, thank you, okay.
Can I just go to page 29, the object fund report, and item 6? Just curious, the fuel and utilities is increasing almost pretty substantially at 1,302%. In FY26 to FY27. What's the reason for that? Very specific.
I believe, well, you can definitely check on it. I believe this is, again, all of the regulatory commissions combined. I could be wrong, but we can check on that and get back to you.
Okay, thank you.
Yeah.
Thank you. Okay, thank you, Delegate Stanko, appreciate it. Okay, seeing no further questions, I want to take a moment to thank our MHCC for being here today, as well as our incredible trauma network individuals. We very much appreciate your service to our state. Thank you. Okay, we are now going to call the remaining executive directors, please, up for the health regulatory commissions, and we'll hear your testimony next. Thank you. Please introduce yourself, reintroduce yourself to us, and then you can begin. Thank you.
All right, I can go first because I made it down first. Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. I'm very grateful to be here today. For the record, I'm John Crom. I'm the Executive Director of the HSCRC. And the FY27 HSCRC budget allowance will allow the agency to continue our core functions, which really focus on healthcare affordability, healthcare quality, and health equity. As a top priority this year as last year, we continue to work closely with hospitals, other state agencies, and stakeholders across the healthcare system to support a successful transition to the Achieving Healthcare Efficiency Through Accountable Design, or AHEAD model. AHEAD provides a strong foundation for continued progress that was made under the total cost of care model and the Maryland model to reduce healthcare cost growth, improve health outcomes, and ensure more robust investment in population health and primary care. In November, Maryland and the Centers for Medicare and Medicaid Services, CMS, signed an amended and restated state agreement for the AHEAD model, and that agreement really reflects almost 2 years of extended and detailed negotiation with strong engagement from across the stakeholder communities. The agreement includes commitments to maintain hospital global budgets and quality metrics across payers to better align and coordinate care, sets goals for primary care spending to expand access and strengthen care delivery, and then enables innovation and system transformation by increasing choice and competition, improving quality, and establishing clear health improvement goals and measures. The AHEAD policy decisions will have system-wide effects across the continuum and require thoughtful, coordinated, and comprehensive policy decisions. So really the work of transitioning to AHEAD has and will continue to involve extensive technical work with the CMS team to evolve the hospital global budget system to meet the new AHEAD requirements. We'll also be doing significant engagement with and participation from stakeholders across the healthcare sector in those policy-making processes. And then, of course, quite a bit of interagency cooperation and collaboration, including the work of the multi-agency regulatory work group that was referenced in Ms. Braun's very thoughtful analysis, which, just to pause for a moment, I do want to thank Ms. Braun, as always, for her really comprehensive work in her budget analysis. The proposed budget will allow HSCRC to continue that vital work, responding to the changing needs in the hospital sector while supporting Marylanders' access to high-quality health care across all delivery settings. I would want to take the bulk of my time, or the remainder of my time, to respond to DLS's observations and questions. First, the first request was for us to comment on how the implementation of hospital assessments may change due to the OBA provision on uniform and broad-based tax requirements. I know Medicaid has spoken to this as well. CMS issued its final rule on Medicaid provider taxes in January. Per that final rule, hospital assessments such as the Maryland Medicaid Deficit Assessment will need to come into compliance by the end of fiscal year 2028. Maryland's current assessments, including that assessment, are under CMS review now, and MDH has requested direct technical assistance from the CMS team to determine if any changes will be needed to maintain compliance once those requirements go into effect. So we're working very closely with the Medicaid team to determine if any changes will be required, and to ensure that the assessment is broad-based and uniform, therefore complying with the new regulations. Second, DLS recommended that MDH submit a report in collaboration with HSCRC on the implementation of new primary care and population health initiatives, including the Medicaid Advanced Primary Care Program, new paths under Medicare primary care efforts, the Population Health Improvement Fund, and the Maryland Primary Care Program, or MDPCP. We concur with that recommendation, and we have already begun the planning work with MDH to do that work. And then finally, DLS recommends the release of $250,000 in special funds based on our submission of a report on incentives for MA plans under the AHEAD model. We thank DLS for its review and for the recommendation to release funds. So with that, I'm happy to answer questions or wait till the end. Yep.
My turn. Madam Chair, members of the subcommittee, it's very nice to see you. I'll keep my remarks very brief. Mark Luckner, Executive Director, Community Health Resource Commission. I wanted to thank Lorianne Moss, who works with me at the commission. She's one of our lead staffers, and she just celebrated her 6-year anniversary in January. So, thanks for sticking with us, January. It's been a time of rapid growth. So, thank you for that, Lorianne. I'd like to begin my testimony by thanking the governor for his allowance. We appreciate every single dollar that he allows us to expend on behalf of our statutory responsibilities. Second, I would like to thank this subcommittee and members of the General Assembly for your ongoing support. As you're aware, our office has grown a great deal over the last couple of years, and so we appreciate that support. Finally, and then I'll turn to the 2 recommendations that Ann offered. I wanted to thank, in particular, Joe and Ann and about 6 other DLS staffers that accepted our invitation. We met upstairs in the Warren Deschanel conference room, let them see firsthand the impact of the grants, and then we went to see 2 programs in Baltimore City. Joe and Ann, thank you very much, and we invite other members of the General Assembly. I know a lot's happening this year, but we'd love to show you firsthand about the impact of our grants. So moving to Ann's 2 recommendations, both of which we concur with. We're happy with the recommendation that the assessment be doubled from $1 million to $2 million in fiscal year 27 only, which I point out Ann says is only in fiscal 27. We're happy to use the remaining fund balance as long as our appropriation in fiscal 27 remains at $8 million. Happy to do that. Second, she asked for more information about how financial need and social determinants of health are impacted into our grant award decisions. At the Community Health Resource Commission, the demand for our grants is highly competitive, and so running a transparent and robust review process is very important. So we consider the following factors in the consortium call for proposals. 1, how did the proposal score on a 100-point scale? 2, the overall students in that school district. 3, financial need, which we use, as Ann pointed out correctly, with the farms rate. 4th, how they fared in terms of local priorities. And then 5th, if they're a returning grantee, how did they perform? And so with that, I'd be happy to answer any questions from members of the subcommittee, and I'd like to close by just giving a shout out to our grantees. In the first year of the program, 136,000 kids were served statewide. 90% satisfaction rates. It's not too many clinicians get that. You can ask, it's pretty. 4 out of every 5 children that got services are now better. They've demonstrated the desired skill. So with that, thank you to the members of the subcommittee, and I'd be happy to answer questions at the appropriate time for the consortium and Community Health Resource Commission. Thanks.
Thank you. Madam Chair, Madam Vice Chair, members of the subcommittee, thank you for your time. My name is Andrew York, and I'm the Executive Director of the Maryland Prescription Drug Affordability Board. I wanted to start by thanking the Moore administration as well as the General Assembly for your continued support, and a special thank you to Ms. Braun for your thoughtful analysis. Just for your reference, we are a small independent agency that was created in 2019 to make prescription drugs more affordable for Marylanders. This is an exciting time for us as we complete our cost review studies of our first 6 drugs, which leads straight into the questions that we received from DLS. First, I just wanted to go over the general timeline for these 6 drugs. So we're currently analyzing 6 drugs, and the conclusion of that process is us publishing a cost review study report, publishing our non-upper payment limit regulations, and then if the board decides to set an upper payment limit, we do that all through regulation, so it would be through a proposed rule. For our first 2 drugs, Farxiga and Jardiance, we expect that to happen early this spring. Our second 2 drugs, Ozempic and Trulicity, probably mid to late spring, and then Skyrizi and Dupixent, we expect to conclude by this fall. In terms of how we're going to update our process and streamline it moving forward, we're at the same time updating the cost review study process. So we've gotten public comments on just how do we make this process cleaner and streamline it easier. So we expect this to become an annual cycle starting in January 1, 27. We're putting out proposed regs probably in our May meeting, and then having that process in place by probably July, sometime this fall. Finally, Ms. Braun asked if we are providing support to the AHEAD model, especially around prescription drug transparency. And I would just like to say we are supporting the interagency work group. We are very excited about the opportunities that are coming with that model and look forward to supporting that group as much as possible. We appreciate this budget, we support this budget, and I'm happy to answer any questions. Thanks.
Thank you so much. Turning to subcommittee members for questions, I see Delegate Stanko.
Thanks, Madam Chair. Just on the prescription drugs, can you talk about how some of the federal changes are maybe making it more challenging or easier, particularly with Trump RX and some of the more commercial strategies to have just a cost-plus strategy to it?
And I think that might, thank you. I would say that we are excited to see action at the federal level. That gives us a lot of, it just shows that there's energy in the space. I would say it's a parallel effort that doesn't directly interact, but one thing we do try to do for Maryland residents is plug them into existing resources. So as much as the federal government is creating these new tools and resources, when patients come to us and say they can't afford drugs, one of the first places we refer them to is some of these services. So we do expect, we think that it's additional and parallel. It doesn't necessarily impact our work.
Gotcha, thank you.
I have kind of a follow-on question, if I may, Mr. York. Thank you first for the important work that you're doing. I know this has been a priority for our now Madam Speaker for a long time, and a number of us who you are witnessing some of the challenges in our healthcare space in general. I want to ask, we're just on the funding side, so forgive me if I'm less familiar with the policy side of your organization, but when you all, or if you all decide that a drug has an upper payment limit that must be set, in addition to, I suppose, the sort of the next thing that happens would be perhaps that the drug company would be required to provide the product for less than the upper payment listed. Do insurance carriers also have any type of obligation related to access for consumers that are insured? Like, for example, are there any utilization management changes that are required?
It's a great question. And it gets pretty technical pretty quickly, but at a very high level, just let me know how much you want me to dive in. At a very high level, when we set an upper payment limit, it basically sets a maximum price that the insurer can pay for that drug. Right now, we're limiting it to state and local government, so the money will flow through the supply chain as normal, but then we basically get supplemental rebates to get to a target net price, and I'm happy to walk through a hypothetical if that's helpful. But all to say that the rest of our supply chain shouldn't really feel any differences, and that's how we plan to do it for state and local government. You guys did pass expansion legislation that goes into effect after we successfully implement for a year for 2 drugs, so it might look a little bit different for that. You were asking if the payers can...
Essentially, are the payers able to pass along the savings generated to consumers?
Correct. The nature of the state and local government insurance is that most patients, like one of the benefits we have working as a public servant is that we get great healthcare coverage. That's one of the best things that comes with working for the state, which means a lot of times that it's a flat fee that we're paying. It's called a co-pay, so $5, $10, $20. So it's very difficult for the insurers to kind of pass that on. Where we think we can have the most benefit is probably outside of this space on something called co-insurance, where it's basically you pay 20% of the cost of the drug. So if we reduce the cost of the drug, then it's going to reduce the patient out-of-pocket costs. You also asked about utilization management. Right now, so what we do is very similar to what Medicare is doing for their Medicare negotiations. I'm not sure if you heard about that through the Inflation Reduction Act. They have not put guardrails or rules for their negotiations. They only require that all Part D plans cover their drugs. So I think we would expect to have a similar rule here. But I think we're hoping to understand the behaviors around utilization management before we start taking strict action on rules and guardrails on utilization management. One thing that we've heard from the payers is that what this is supposed to do is reduce the cost to the payer. So just, you would think that the payers would try to cover these drugs and expect them to cover these drugs. Right now we don't have specific rules around utilization management, but it's something we can explore.
Okay, got it. Are there currently any bills related to this issue that would require carriers to pass along the savings, say, by example, restricting utilization management? And if so, would PDAB take a position on something like that?
There is a bill, and I should have it pulled up now, that basically is specifically around utilization management related to drugs. It was whether or not they were studied by the board. Now there's an amendment that limits it to whether or not an upper payment limit was set. We submitted a letter of opposition mainly because we are worried about the potential unintended consequences. So what we've heard from payers during that testimony is basically like utilization management is not just a cost issue, it's also, there's clinical issues associated with it. So if you do these blanket bans of utilization management, you can actually end up harming patients because the payers say that they use these tools to ensure safety for the patient at the same time. So you just want to make sure you're thoughtful in how you do that. Go ahead.
Yeah, I mean, having experienced this on the patient side,
Yes.
I have a hard time believing that a doctor that is actually prescribing a drug would not have that same patient safety concern while looking at their own patient's chart that an insurance company would be uniquely managed, like able to manage from a broader utilization management tool. But I appreciate PDAB weighing in and providing these thoughts. I'll turn to Delegate Ruff for questions.
Thank you, Madam Chair. I wanted to touch base with Director Crum. How are you doing today? Indeed. I wanted to know if you had a chance to review the letter that I sent you this afternoon.
Yes, I
know
just saw it.
Very recently.
Yeah, I just saw it.
I apologize. I tried to get it to you earlier. So I think at the end of the day, it's clear that I am in disagreement with the finding of DLS about the responsiveness of your report to our JCR language. And I was wondering if you had had a chance to, in the short time that you had a chance to look at my letter, respond to any of the things I was discussing, where I was talking about not responding to questions about utilization savings, methodology, proposed interventions to reduce hospital use. And this is all for context around the Medicaid Advantage program and the state's efforts to stabilize those programs. So I guess as a start, and if you could think about those responses, do you acknowledge that the instability of the Medicare Advantage program in state is a significant issue?
So one, thank you for the letter, and happy to respond in greater detail as we have a little bit more time to process. But I would say we did take that issue very seriously, and it's one of the reasons why there's very clearly a shift midstream in our approach, right? So what we outlined in the report was a mechanism or a policy proposal that we had really functionally starting 18 months ago to use one mechanism under the total cost of care model to provide funding in order to stabilize the market. That is no longer available to us under the AHEAD model. In fact, what they've explicitly allowed is that kind of differential adjustment that is outlined in now the multi-agency work group kind of report out on that proposal. So that's really what's driving the shift in approaches, among other things, right? Is kind of this negotiation with the AHEAD model and what's really available to us, right, as a potential solution for MA stability.
Right. I was just trying to get your take.
Yeah.
Do you believe that the instability of the program is a significant problem in our state?
Yes, and that's why that measure is significant in its approach.
I think it's an issue right now. However, the proposed solution isn't going to be implemented until January 1 of 2027. Is that correct?
Correct. Yes.
Is there any reason why we're not trying to implement something now, understanding that MA programs lost just about $400 million last year, or in calendar year 24. 50,000 beneficiaries lost their benefits last year just from a couple of programs. They're very, it seems like limited programs still available. And all of that, in spite of the fact that seniors are really trying to take advantage of this program. Is there a reason? Can you tell us why we're not starting until January?
Yes, Delegate. Yes. through that multi-agency work group process, what we tried to balance, and we heard from a number of stakeholders, as you mentioned in your letter, the mechanism that we have available to us is this differential adjustment, right? So where we're offering a discount, right, for hospital rates for MA plans, but we have to offset that, right, for in rates to other payers. The challenge there is that those rates are already set, right? And so there has to be some runway for those other payers in order to ensure that we're not creating shocks to the system as we go. So while we can recognize that there are financial challenges for MA plans in 2026, what we're trying to balance out here is the long-term sustainability for both MA plans as well as other payers, and ensuring as best as possible that we can lock in and over the long run provide sustainability and access to those to the value proposition of MA plans, which is quite frankly, right, limiting and reducing the out-of-pocket burden for seniors who are relatively low income.
Okay. If and I completely understand the impracticability or the impossibility of moving forward sooner. If that is the case, since that's the case, is there any consideration with renewing or restoring the Hospital Medicare Advantage grant program that was initially used to attempt to stabilize the market, which has had mixed, obviously, results in the interim, so that we are able to preserve the Medicare Advantage programs that we have right now? Because as I mentioned to you last year, you know, there's about 10,000 seniors in Northwest Baltimore and then the other side of this county, of the county-city line, that are, you know, have taken advantage of this program. I'm not sure how many of them are still in the program, but 80% of them are African-American elders who are, you know, in underserved communities. Is that a possibility that HSCRC can consider reinstating?
So it was something that the multi-agency work group did consider pretty significantly, and there were a couple key concerns, right? One was, again, the mechanism, it's functionally the same, right? So in other words, in order to do those grant programs, you would have the impact on payers, right, that I described for, you know, what is contemplated here. The other concern was that was really on making sure that the requirements that multi-agency work group put into place as conditions on the funding, which really get at root to some of the concerns that you're describing. So one of the things that was very important to the stakeholder community was that the plans who are receiving those funds or those discounts had more than 50% of their membership in Maryland. So in other words, Maryland ratepayer dollars staying in Maryland. But then also additionally putting some minimum thresholds in terms of how much of the membership could be in should be in lower income counties within the state. Those are really critical, I think, consumer protections that get into what you're describing. I think the challenge there was, again, runway and how quickly we could put that program into place. So balancing a number of those considerations, that's where that multi-agency working group landed.
Okay. Well, I look forward to the response. I do think that there are several pieces of our budget language that have not been addressed yet. I think that those are critical for us to be able to understand the fiscal implications of the current proposal. And I would like to figure out how we can preserve as many of these MA providers as possible in the meantime, because I would hate for us to be in January and have a plan ready to implement and there be very few or no organizations available to take advantage of it and to provide this necessary kind of lower rate health insurance for our elders. So thank you so much, and it's
sir.
great to see you in person this year.
Yeah, good to see you, and thank you, and we will follow up with some responses.
Indeed, thank you. Thank you,
Thank
Madam
you,
Chair.
Delegate Ruff. Thank you, Mr. Crum. I have a question for you, Mr. Crum. I want to talk about the uncompensated care fund, please, and some of the uncertainty that exists there. So on pages 7 and 8 of the DLS analysis, really thoroughly explains how the trends that we have seen due to the ACA expansion between 2010 and 24 have led to a decrease in and uninsured Marylanders, but it's really not clear this time whether this trend is going to continue due to HR 1. So the UCF, for FY27, it's likely going to shrink to $130 million for FY27 from $135 million in FY26. How are we preparing for the scenario in which uncompensated care could increase to our acute hospitals based on changes in HR 1?
Yes, Madam Chair, thank you for the question. So I would mention two things. One is that we have just kicked off our annual update factor process, right, which is the kind of the main point in the year where we make adjustments to hospital rates functionally that go into effect in July. As part of that process this year, we are looking at uncompensated care, and we're in process, particularly working with Medicaid right now, in establishing estimates. They've put out estimates on the number of Medicaid members who they are anticipating could have coverage disruptions. What I would flag there is that the pull-through isn't direct to those who would be uncompensated, that for hospital patients who would be uncovered. The reason being is a couple-fold. One is that there are the availability of emergency Medicaid, right? So you could have a coverage disruption and then be eligible for emergency Medicaid that would cover your hospital costs. The other is some of the coverage disruptions related to redeterminations. Hospital presumptive eligibility also can be an effective tool for reducing the uncompensated care for those populations. So both of those tools, we're working with Medicaid right now to understand, what is the expectation in terms of ramping up the eligibility processes to make sure that hospitals and patients are taking advantage of those eligibility categories, and then therefore upfront reducing the amount of uncompensated care that we would expect I think we are really trying to ensure that we're happy path on those eligibility determinations as best as possible, and then being precise about our estimates about what we think the impact will be on uncompensated care, really starting in 2027.
Thank you. And just last to you again, Mr. Crum, I just want to thank you and MDH and the administration for really keeping the General Assembly very informed as you all were negotiating on the AHEAD model. That was a wild ride that you all had to go through. I think there still remains some lingering questions about what will happen in a couple of years. And so I just want to ask, and I know you will, and I don't have to ask, but just want to ask for your continued communication with us as you all, and with advocates and with the hospitals and all of the stakeholders as we roll into the next version of the total cost of care in Maryland. So
we will absolutely be committed to it, and it really strengthens our work to be able to have your partnership in those negotiations, and then as we go forward in the policy development.
excellent. Thank you so much. Thank you all. Really appreciate you being here today. We have 4 more witnesses, I believe, for this budget hearing. So we've got Ann Geddes with the Mental Health Association of Maryland. We have Alyssa Sanders with Every Mind, Michael Gray with NAMI of Maryland, and Kenzie Funk with Strong Schools Maryland. I think we can all fit at the table. Once you all are seated, you can begin with your 2 minutes. Our awesome counsel, Joe, will time you, and we'll go from there. Thank you.
I'm Ann Geddes. I'm the Director of Child and Older Adult Policy at Mental Health Association of Maryland, here in support of full funding for the CHRC and the Consortium on Coordinated Community Supports. The blueprint legislation established funding.
Excuse me, I'm sorry. I forgot to ask our executive directors, sorry, can you all, could someone back there just grab them? We like to have everybody listen to advocates before they leave. I did not do that courtesy reminder and didn't realize they were leaving. Can you just, one moment while they come back in? Just would love for them to hear you.
Yeah, I appreciate it.
Sorry, guys. I forgot to do our courtesy reminder that we like for our agencies to please listen to our advocates who have signed up to testify before you leave today. Really appreciate it. Thank you. You may continue.
Thank you. So the blueprint legislation established funding for school behavioral health services to be managed by the consortium. Last year, the BRFA proposed cutting the fund by $80 million. We thank the legislature for restoring much of that funding. This year, the BRFA again proposes cutting the fund, this time by $20 million. This cut would have a devastating impact on children and youth. We know that the need for mental health and substance use care has never been greater. Children and youth are experiencing behavioral health concerns at record-breaking numbers. And we know that schools are an important place to provide behavioral health services. They allow for easy access to care, and only schools can engage in prevention and early intervention activities before a problem raises to the level of needing formal treatment. Over the last 2 years, consortium grantees have achieved exceptional reach and results. Last year, over 136,000 students were served in 86% of Maryland schools. Students demonstrated significant improvement across all 3 levels of intervention, and 90% of students and families reported satisfaction with the services. A 20% cut in funding would cause many programs to shut down. Investments made thus far would be lost, and students would be harmed. Quality, accessible behavioral health care is essential to the well-being of our children. We urge you to continue to invest in accessible and effective care, and we thank you for your support.
Chair Shetty, Vice Chair Jones, and members of the subcommittee, my name is Alyssa Sanders, and I'm Director of Advocacy at a nonprofit called Every Mind. For nearly 70 years, Every Mind has walked alongside Maryland families in their hardest moments, providing prevention, early intervention, and life-saving mental health care. I'm here today, just like Ann, to ask you to restore the proposed $20 million cut to the Consortium for Coordinated Community Supports. A 20% cut to school mental health funding is not trimming a line item. It is pulling away support from children in crisis. Every Mind's clinicians, case managers, and mentors are trusted partners inside school communities, including in 13 consortium-funded schools. They provide therapy, mentoring, case management, and support for families and staff. This funding doesn't sit in a budget line. It walks school hallways and sits beside students when they are at their lowest. Nearly 40% of Maryland high school students report feeling persistently sad or hopeless. We know that suicidal ideation among our youth has surged. These are not abstract numbers. These are students sitting in classrooms right now carrying trauma, anxiety, and depression, often silently. So one student who we worked with came to us angry and repeatedly suspended, acting out because of trauma at home. While others saw behavior, we saw pain. With consistent mentoring from a trusted adult who showed up every day, she's gone this entire year without one suspension. Her grades are up. She's using her words instead of her fists. And for the first time, she's talking about her future. That transformation happened because funding allowed a trained adult to be there consistently. Now multiply her story by thousands. If this cut stands, services will shrink, staff will be lost, and children will be the ones paying the price. You have the power to choose differently, restore this funding, protect these services, protect our children. Thank you.
Good afternoon, Chair, Vice Chair, and members of the subcommittee. My name is Kenzie Funk, and I'm the policy advocate at Strong Schools Maryland. I'm here to urge you to restore the Consortium on Coordinated Community Supports in the Health Regulatory Commission's budget. Across Maryland right now, there are students sitting in classrooms who want to learn but simply cannot focus because they are struggling with anxiety, depression, or trauma. For too many of them, school is the only place they might ever access help. We know the scale of the problem. About 1 in 6 young people struggle with mental illness, yet fewer than 20% receive adequate treatment. That means that thousands of Maryland students are trying to succeed in school while carrying challenges and burdens they cannot manage alone. These aren't just statistics, they represent students struggling, falling behind, and lacking the support that they need. The consortium was created to close that gap. In the last year, it has provided behavioral health services to more than 136,000 students across 80% of our public schools. Students are finally starting to receive the care they need, and schools are becoming better equipped to support them. But despite this progress, the current proposal cuts funding for the consortium by another 20%, on top of the $30 million reduction made last year. That means fewer services and fewer students getting help at the exact moment this program is beginning to work, and when the need for these services is anecdotally getting bigger. Yes, the state faces a fiscal shortfall, but the simple truth is that this budget asks students to bear a disproportionate share of fiscal pain. Investing in behavioral health services improves academic outcomes, reduces disciplinary actions, and saves money in healthcare and public safety. Just 1 week ago, students from across Maryland stood outside in the cold and the snow for Blueprint Day. They came to Annapolis with a simple message: invest in us and invest in our well-being. On behalf of those students, we urge the committee to restore the consortium's $100 million funding for fiscal year 2027 and beyond. Our students cannot afford these cuts. Thank you, and I'm happy to take questions.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Michael Gray. I'm with NAMI Maryland. That's the state organization of the National Alliance on Mental Illness. We represent a network of over 60,000 individuals who are impacted by mental illness directly, as well as their families and their communities and mental health providers. So thank you for your time today to consider this very important issue. And I had the benefit of going last. You've heard all the facts and figures. So I want to say that NAMI agrees 100% with everything you just heard from these three advocates. And we want to urge you to remember who we're trying to help here. If we can't find a way to fully fund services for youth in need of mental health services, then who can we help? It's not just an investment, because that implies you won't see returns for a long time. The issue with the consortium funding is that if you fund it, you will see the results right away, and you'll see the long-term results as these youth and kids grow up. If you don't fund it, you'll see some bad results right away, but most of them years later, when adults who needed services as youths couldn't access them. So again, thank you so much for your time today, and please restore this to $100 million.
Thank you so much. Do you have any questions from subcommittee members? Thank you for your testimony. Okay, that concludes our testimony for the Health Regulatory Commissions. Thank you, directors, for coming back in. Appreciate it. Apologies for not doing my reminder in advance. We will now proceed to we're going to go a little bit in a different order than initially planned. We're going to do the Child Support Administration, if possible, please, because I'd like to be here for part of that before I have to head to rules. So thank you. Thank you for your understanding. So we'll invite thank you. We'll invite Connor from Department of Legislative Services to come share the Department of Legislative Services analysis. Thank you so much.
Thank you, Madam Chair. Good afternoon. My name is Connor Brown, Policy Analyst with the Department of Legislative Services, here to present the fiscal 2027 budget analysis for the Department of Human Services Child Support Administration, or DHS-CSA. To begin, on page 1 of the analysis, the fiscal 2027 budget for CSA increases by $23.9 million, or 21.3%, to $136.1 million. On page 2, there are 5 proposed deficiencies in CSA, totaling $3.7 million. The largest, making up almost half, is for the Constituent Services Call Center. As was discussed in the DHS administration analysis, this is part of a larger realignment that overall decreases the fiscal 2026 appropriation. There's also a proposed deficiency of almost $1 million for child support services in Baltimore City, which are handled by a private contractor. Although a new contract was approved by the Board of Public Works back in June of 2024, DHS indicates that the contract amount was not fully accounted for in the fiscal 2026 budget formulation process, including a one-time transition fee that was incurred back in fiscal 2025. DHS should comment on why the portion of the shortfall that related to the transition fee from fiscal 25 was not paid using the fiscal 2025 appropriation or reported to the Comptroller's Office at closeout if there was insufficient appropriation. On page 4, Exhibit 1 shows an overview of agency spending in fiscal 2027. Moving to page 5, Exhibit 2 outlines line item changes in the fiscal 2027 allowance compared to fiscal 26. One of the increases is an addition of $600,000 for job readiness training and personal development for non-custodial parents. However, about $680,000 is included for the same purpose in the Family Investment Administration, which is level funded with prior years. DHS has reported that the funding in CSA is not a new contract, but rather a new fund source for the same services. The Department of Legislative Services, or DLS, recommends reducing DHS's fiscal 2027 appropriation by the $679,639 amount to correct the apparent double budgeting of non-custodial parent training contracts. The largest increase in the allowance is for cooperative reimbursement agreements. Those are agreements with local agencies that assume child support functions. Those agencies receive a 66% match from the federal government, and those funds are centrally budgeted in CSA. As shown in Exhibit 3 on page 7, funding for these agreements has varied widely over the last several years. DHS should comment on the substantial variation in those expenditures across years, as well as why fiscal 2025 actual spending was $23.5 million below spending in fiscal 2024. Beginning at the bottom of page 7 is a discussion of the Child Support Reinvestment Fund, which holds federal incentive payments based on performance against 5 measures set by the Federal Office of Child Support Enforcement. On page 9, Exhibit 4 outlines reported revenue into this fund, as reported by DHS and the governor's budget books. As you can see, reported revenue is not consistent across sources, with fiscal 2024 showing an especially notable difference. Additionally, the fiscal 2025 closing balance of the Child Support Reinvestment Fund differs significantly by source, with the Comptroller's Office reporting a closing balance of less than $1 million, and DHS reporting that amount at over $15 million. DHS should comment on the discrepancies in Child Support Reinvestment Fund revenue and balance reported between sources. On page 10, Exhibit 5 shows expenditures from the Child Support Reinvestment Fund. Unlike most other funds, DHS cannot use these funds to draw down the typical 66% federal fund participation. However, several of the proposed deficiency appropriations add both funds from this source as well as what appear to be federal matching funds. DHS should comment on how the agency will address any potential shortfalls resulting from including federal matching funds in appropriations that utilize the Child Support Reinvestment Fund. Additionally, beginning in fiscal 2025, DHS has made appropriations from the Child Support Reinvestment Fund in areas that have not traditionally received funds from that source and do not have an apparent relation to child support functions. DHS should comment on why child support reinvestment funds are being used for sources outside of CSA or local child support enforcement functions, as well as how these uses support child support service activities. DHS should also comment on the limited budgeting of funds from this source in fiscal 2026 and 2027, despite reporting a fiscal 25 closing balance of over $15 million and having received additional funds since that time. On page 11 is the personnel section. As of December 31st, 2025, CSA had 49.5 vacant positions. The vast majority of those had been vacant less than a year. The key observations section begins on page 12 with a discussion of child support performance using the 5 federal incentive measures that I mentioned earlier. Exhibit 6 on page 13 shows statewide performance in 4 of those measures at federal fiscal year close compared to both federal and state goals. All measures declined compared to fiscal 2024, each of them by less than 1 percentage point. Exhibit 7 on page 14 shows the 5th measure, cost effectiveness, including an estimate provided by DHS for fiscal 2025. Between fiscal 2021 and 2024, cost effectiveness fell each year, reaching about $2.50 collected for every $1 spent in fiscal 2024, about half of the federal goal. DHS estimates that cost effectiveness saw substantial improvement in fiscal 2025 and reports that the actual cost effectiveness number will be available in April. On page 15, Exhibit 8 shows jurisdictions that did not meet the state goal for the 4 federal incentive measures, also at federal fiscal year close. Overall, 5 jurisdictions met or exceeded all 4 goals measured, while 3 did not meet any of the goals. However, DHS did report that the jurisdiction level data was only preliminary and final data was reported to the federal government at the end of December. DHS should comment on any changes between the preliminary data and final numbers for federal fiscal 2025. Additionally, DHS should comment on measures being taken to improve local performance in the federal incentive goals. On page 16, Issue 2 discusses the Child Support Management System, which was implemented beginning in 2022. A big topic in recent years has been federal certification of the system, and DHS reports that the certification process finally began in January, and they anticipate final certification will be received in July. On page 17, Issue 3 discusses motor vehicle license suspensions, including changes that were made to the process by Chapter 578 of 2025. DHS should discuss its efforts to implement the changes in the driver's license suspension program. Additionally, in April of last year, the Office of Legislative Audits published an audit of CSA that contained one finding, which was that CSA did not have sufficient procedures to ensure that the Motor Vehicle Administration suspended the licenses of non-custodial parents who were delinquent in their child support payments. CSA noted that they would implement a new report for local offices to locate and resolve potential data entry issues and provide training on how to utilize the report. DHS should comment on specific steps being taken to ensure that local offices are utilizing this report to address rejected referrals. On pages 19 through 21 are a list of DLS recommended actions. In addition to the one already discussed, DLS recommends committee narrative requesting 3 reports on performance data against the 5 federal incentive payment measures, which has been a request over the last several years. Additionally, DLS recommends committee narrative requesting a reconciliation of the Child Support Reinvestment Fund, including revenue, expenditures, and balance information for fiscal 2019 through fiscal 2026. And finally, DLS recommends deleting the special fund deficiency for the Constituent Services Call Center, as was discussed in the analysis for the DHS administration, to more closely align with the agency's projected need based on their contract details. And with that, I conclude my presentation, but I'm happy to answer any questions.
Wonderful. Thank you for the thorough and thoughtful analysis. Questions from the subcommittee? Seeing none, appreciate you. We will now call down our DHS friends to join us at the table, please, for your response. Thank you.
Should I press the button? Good afternoon, Chair Shetty and members of the subcommittee. I'm Gloria Brown Burnett, Interim Secretary here at the Department of Human Services. I want to acknowledge my team, including Chief Financial Officer Roman Napoli, Jarnis Johnson, Executive Director of our Child Support Administration, and Aaron Easton, Child Support Administration's Chief of Staff. And thank you, Mr. Brown, as always, for your very thorough analysis. Members of our leadership team are also in the audience, including Courtney Thomas Winterberg, Director of the Allegheny County Department of Social Services, whom you will see in a different role when we do our next hearing. The mission of our Child Support Administration is to encourage responsible parenting, family self-sufficiency, and child well-being. We work with parents to provide financial, medical, and emotional support their children need to grow and thrive. In federal fiscal year 2025, CSA collected and distributed $450 million in child support payments and served over 155,000 Maryland families. In 2025, we updated license suspension, our license suspension program, a legislative Black Caucus top priority, and changed the noncompliance timeline for a referral to the Motor Vehicle Administration for suspension from 60 days to 120 days. These new legislative changes also exempted non-custodial parents whose income is at or below 250% of the current federal poverty level. We made system changes to implement the changes to the definition of actual adjusted income to include a deduction for each child living in the parent's home for whom the parent owes a duty to support. Additionally, we hosted a statewide amnesty program which collected over $790,000 in previously unpaid child support and reinstated 2,383 driver's licenses. We celebrated the 50th anniversary of Title 4D, the Title 4D child support program, by hosting a series of events and resource fairs and highlighting our payment incentive program to help non-custodial parents reduce their arrears. Within DHS, we've improved the interface between the child support management system and our eligibility and enrollment system to better exchange data. This increased data match rate across programs to 82%. In 2026, we're prioritizing increasing and enhancing partnerships with community-based partners to develop additional non-custodial parent employment programs to help those who need job skills and create employment opportunities. We're also fostering a culture of performance improvement through clear communication of performance expectations and metrics to all employees. And we're continuing to develop the requirements to implement the new child support pass-through requirements that will require us to pass through 100% of the child support to current recipients receiving public assistance over a 4-year period. I'm going to now turn it over to Aaron Easton to begin our response to the DLS prompts.
Good afternoon, Madam Chair, Vice Chair, and members of the subcommittee. The department was asked to respond to the comment on page 2 of the analysis regarding the shortfall of the Baltimore City contract and why the portion of the shortfall that related to the transition fee from fiscal year 2025 was not paid using fiscal year 2025 appropriation. The fiscal year 25 budget request was submitted using the old contract's cost information because the budget was submitted prior to the new contract being awarded. The transition fee was paid during 2025 fiscal year. The department was asked to comment on the recommendation on page 5 to reduce DHS's fiscal year 2027 appropriation by $679,639 to correct the double budgeting of non-custodial parent training contracts. We respectfully do not concur with this recommendation and the DLS assessment that this is a duplication of funding. Using Title 4D funding in addition to the funding budgeted in FIA will allow for the expansion of the program to include a re-entry component for previously incarcerated non-custodial parents. The program will provide services such as job placement, legal aid for order modifications, and arrearage reduction. The programs often begin during incarceration to assist with financial planning, job readiness, and family reconciliation. If funding is lost, we would not be able to expand our program to include reentry services. The department was asked to respond to page 6 of the analysis on the variation in CRA expenditures across years and why fiscal year 25 actual spending was $23.4 million below spending in fiscal year 24. While we are working to identify why reported CRA expenditures decreased in fiscal year 25 compared to 24, we believe the expenditures shown in the chart for federal fiscal year 24 are actually contract amounts and not actual spending. It appears the department encumbered the entire contract amount, contributing to the spike shown in the chart. Please note that some of these contracts are multi-year contracts. The actual expenditures for all cooperative and reimbursement agreements in federal fiscal year 24 is $17.4 million. The expenditures for federal fiscal year 25 stands as of today at $11.4 million, with an additional $1 million in invoices in the review process. We would also like to note the term of these contracts runs on a federal fiscal year, and we also track the expenditures on a federal fiscal year, not a state fiscal year. I will now turn it over to Roman for the next responses.
On the discrepancies in child support reinvestment fund revenue and balance reported between sources noted on page 7, we believe that there may have been some miscommunication about how the word revenue was used across multiple meanings. For instance, the term refers to new funds awarded by the federal government for a given year, and in other instances, it refers to the fund sources assigned to a given amount of expenditures in a year. This has caused some confusion in our initial responses, and additionally, DHS must estimate how much it will award in each year, meaning the amount of funds received may change depending on when the data was reported. The amount that Maryland received is based on the second preceding year's performance, yet DHS plans its budget 1 year in advance of when the governor's allowance is presented and the appropriation year begins. This causes a timing misalignment which impacts DHS's ability to accurately estimate revenues. We plan to work with our DLS colleagues on how we can better report on this information moving forward, including the balances. On how DHS will address any potential shortfalls resulting from including federal matching funds and appropriations utilizing the child support reinvestment funds. Per federal statute, we do not use CSRF to match federal funds. We intend for this 2026 deficiency to be 100% funded with the CSRF. For comment on page 11 on why child support reinvestment funds are being used for sources outside of CSA and LDSS child support enforcement functions and how they support child support activities, the 2025 CSRF budget amendment for $4 million was mistakenly recorded under FIA local offices, but was used for allowable expenditures. When DHS entered the 2025 expenditures into the state DBM's BAR system, we did not report a correct amount for CSF expenditures in this line compared to what we reported in our own financial systems. DBM inputted a technical review adjustment to ensure the budget book for 2025 more closely reflected the amount of CSRF spent across the agency in that year, informed by prior year expenditures. The adjustment incorrectly displayed the figure in the G002 CSRF funds, and they were not used to draw down matching funds. FEMA's entries, which is our financial system, showed that the CSRF fund was spent only in H008 and G006 in 2025. The 2026 deficiency for foster care maintenance payments includes a $750,000 in CSRF to address a funding shortfall. The correct fund source for this budget item should have been the foster care offset in 00334. The 2027 CSRF funding in the Office of the Secretary is for the DHS call center, which we discussed earlier. Now to turn it over to Jarnes.
Thank you. Good afternoon, Madam Chair and Madam Vice Chair and Subcommittee members. On the changes between the preliminary data and final numbers reported to HHS noted on page 14 and measures being taken to improve the local Department of Social Services performance in the federal incentive goals. There were no changes in the performance data that was submitted to HHS. CSA has implemented mandatory training and is working to provide additional tools in our local leadership in an effort to work on performance consistently throughout the federal fiscal year. We are meeting with local leadership quarterly to specifically review ways to improve performance and to identify any barriers that are seen locally to meeting performance goals. We also developed a new orientation series to assist new directors and assistant directors in understanding the child support program. On efforts to implement the changes in the driver's license suspension program as outlined on page 17. In 5 months, we completely rebuilt and restructured the entire driver's license suspension program, as well as delivered statewide training and additional resources to local offices to implement 2025's legislation. Staff were trained not only in the changes in the law, but the entire change of process for the program. As a result, to date, there have been 0 licenses suspended by DHS since the new law was implemented in October of 2025. On the specific steps taken to ensure that the local departments of social services are utilizing the no-match report to address rejected referrals as noted on page 18. CSA has conducted mandatory training and submitted a quarterly review of the report to ensure that the local offices are working on the report and recording efforts to update the data where possible. These referrals were made prior to the change in the law and the driver's license suspension program implementation in October. Since that time, we have not been able to select individuals for the driver's license suspension, resulting in no rejected referrals since October 1 of 2025. Response to DLS operating recommended actions on page 19 of the DLS analysis. On the recommendation to reduce federal funds for non-custodial parent employment and training contracts. As noted in our response to number 2 above, we respectfully do not concur with this reduction and the DLS assessment that this is a duplication of a request for funding. The intent of this request is to expand the level of services provided to our customers. Utilizing 4D funding will allow for the expansion of the program to include a reentry component for previously incarcerated non-custodial parents. The Child Support Reentry Program will help formerly incarcerated individuals manage or modify child support obligations, which prevents debt accumulation and supports successful reintegration. We concur with the recommendation in number 2 for the child support performance reports. We also concur with the recommendation for a report on the reconciliation of the Child Support Reinvestment Fund, on the recommendation to add language regarding N00H0008 Child Support State Child Support Administration. We respectfully do not concur. As discussed at our earlier budget hearings, the funding split for the Constituent Services Call Center contract must maintain a balance of general, special, and federal funds aligned to the grants and sources that fund that program. The special fund authority to fund the contract and operations must be maintained. DHS and DBM undertook a multi-step process to more accurately reflect the cost centers for the call center contract for federal fiscal year 26 and 27. As a result, total call center spending across the agency decreased, though realigning funds to the correct cost centers meant some programs and fund types saw funding increases while others saw decreases. And I'll turn it back over to our secretary.
And at this time, we are happy to take your questions. Did I say happy? I don't know if I'm happy.
Happy's a little step beyond, huh? Well, thank you so much for being here. I see Delegate Stanko has a question.
Thank you, Madam Chair. I have a question for your CFO. And starting high level and then getting into some questions around the call center specifically. And you've been on the job now for what, like 120 days-ish? Yeah, so I know a lot of this, but one of the things that I'm trying to kind of drill in is as we move into this fiscal year, into the next, round of hearings next year, kind of breaking out operational questions from finance questions. And, you know, we just got a good kind of overview on some operational questions. And so as you stepped into the role at a higher level, can you talk about the challenges that you've been addressing and how you're addressing them, both from an FP&A side and from a controller side? And so really want to kind of get an understanding is, have the challenges that you've seen, and I think about the call center, and I'll, you know, follow up with that, but has it been more of where process driven around where payments are going, how payments are being received, or we're putting stuff in wrong buckets because our budgeting is off?
Yeah, I think I would flag sort of two very clear things that have hit me in my early time and tenure, which is, one, how manual each and every one of these systems is. We individually allocate every single change. So the call center is a great example of where we tried to fix something and we didn't exactly perfectly get it right, because we're sitting here manually moving line items to try to make corrections.
In an Excel file, essentially.
Yeah, to reflect it in the budget book.
Yep.
The budget book is not tied directly to our financial system. The financial system is not directly tied to our invoicing system.
Okay.
I can go, but the point is just how every bit of the process requires sort of manual accuracy, and that's a much higher bar than I think we've sort of been operating at, you know, and so even cleaning things up gets complicated. Then the second piece I would just flag is, you know, on the controller side, we've also had a number of things that we've been trying to fix. And so what you find yourself doing is sort of, how many of these things can I fix today? And then how many things am I going to have to say, okay, that's going to be a closeout issue, that's going to be a next budget year issue. Those are the kinds of sequencing we're having to do as we sort of kick over rocks and find things that just need to be corrected.
Okay, and you're using, it's like, you know, multitudes of systems. You don't have a centralized ERP, essentially.
So the way I would frame it is, we have a budgeting and a finance system, and but we do not have what I would call an integrated, you know, sort of invoice procurement, and we're sort of working in that direction with the OpenGov. But the one last step is, then at no point do our grants tie into any of those systems. So all of the calculations, grant by grant, for the 70-plus grants that we have, all are done manually and outside of the systems.
Okay, as a follow-up to that, drilling down into the call center specifically, and it's a pretty material amount of your budget. I think it's like 2% of the entire agency budget, so it's not, you know, we could use that in absolute dollars, but that's a big number. Can you just elaborate specifically? There's a comment on page 2 of misapplication of allocation percentages for invoice payments. And so if I understand that right, that's more of a controller issue then, correct? Like you're drilling down, your folks in the AP, I guess APAR world are putting them in the wrong invoices, or putting them in the wrong, we'll call it the budget column for the sake of how you define your last answer.
You know what, I'm hearing your question, but I just want to say, I don't think I want to go off the cuff.
Okay.
I want to give you a better answer than that, but just to say, I do think for my purposes, what I would say is like, we are trying to get it right at every step of the process, and I haven't seen anything that is more egregious, that is misaligned versus being wrong. Those are sort of can be two different things in the financing side. So let me get back to you with a more detailed answer.
And so my last question, Madam Chair, I appreciate the latitude, is as you think about this year, right, and the role you're in, you get to next year, what are the main things that, I mean, you broke down some individual items, but what are the main things that you're doing from your level and your role to get to where next year a lot of those process questions are, like secondary controls that you have in place that you've instituted with your folks to make sure that those questions are not repeated throughout the, you know, multitude of last hearings?
Yeah, I have turned over or had turnover in 10 of the top 12 positions. And I think that is something that, getting a year under our belt, the group that we have now, that's going to be a big asset. But sometimes it's, you know, just knowing the right questions to ask, and then having feedback like these documents. This is a totally independent perspective of our budget that I got 2 weeks ago. And so processing this has been really useful, and we've actually admitted to our colleagues in DLS that there are things like, oh, good catch, thank you, we didn't see this. Oh, we didn't notice that this and this had become misaligned. I think that those are all data points that this new leadership team's pulling together.
Okay, thank you, thank you.
Thank you, Delegate. Delegate Ruff, before you have to run to Capitol.
Thank you, Madam Chair, for giving my disclaimer out there for me. And thank you to the panel. I wanted to know, I appreciated the reference to the Black Caucus priority on the license suspension bill, which I was a co-sponsor of. Little plug. But anyway, I wanted to follow up on a different piece of legislation that I don't believe was referenced in your testimony yet, talking about House Bill 1126, which created the Child Support Arrears to Work pilot program in the last session, which required the department to work with the Department of Labor and DBM to establish and implement this program. And I was the sponsor of that bill and wanted to know if there was any update that you could provide in advance of the report that's going to be due on July 1.
I'm sorry, I do not have an update that I can readily give you, but we are absolutely, we're certain we can get back to you.
Okay. Thank you, Madam Chair.
Thank you, appreciate it. Madam Vice Chair.
Thank you so much, Madam Chair. Thank you all for being here and for your patience. It's a very busy day as we get close to crossover. Quickly, it's great to see the DHS has consistently met statewide performance goals. But when we look at Exhibit 6 of the DLS analysis, DHS has fallen approximately 20% short of the federal goal for current support collections and approximately 10% short of the goal for cases paying in errors. So I was wondering if maybe you could share what specific efforts DHS is taking to meet the federal goal in these two performance measures.
Sure, thank you.
Thank you.
We have been training our staff. That's first and foremost on statewide. We've implemented several mandatory reports to assist our staff in meeting those performance goals. And I also wanted to add that while we may not be meeting several of the goals, it has not reduced our incentives, nor have we received any penalties. Because under the federal regulations, as long as you continue to increase and you don't fall below a certain percentage, I'll give you an example. For support order establishment rate, even though the federal government requires you to meet 80%, if you are between 40 to 59 or you stay above 50%, there is no penalties and there's no reduction in the incentives. So we may not be meeting the state goal or the federal goal. We have not incurred any penalties or reduction in our incentive amounts.
I appreciate that, for sure, that clarification. But do you feel that it was only due to staff, or to training of staff was the only reason?
No, I wouldn't say that exactly. When you look at the national trends regarding the performance, and especially in the areas of collections are down nationwide. So we are consistent with what's going on nationally. I can't say that it's systems. It could be new staff coming on board because, as you know, as people like me, as we age out of the system, there are more new people coming on board. That's why we have done statewide training on all of the federal performance measures. We've increased the performance goals for each of our local offices and to ensure that we're meeting those standards. We have, we're meeting with the local DSS leadership quarterly in a quarterly performance meeting to go over those barriers, to address barriers, preventing them from meeting the child support performance, such as case closure, case maintenance, and different best practices that they can use to increase their performance. We've also looked at the statewide amnesty program. This year, we actually expanded that to a 3-month versus just a 30-day to assist with the paternity cases paying on arrears and so forth and so on. So that's what we're looking at with our local offices to increase the performance. But the quarterly meetings seem to help a lot because all of the local leadership can come in one venue and we can discuss those things such as barriers to performance.
Thank you, ma'am. I have a question related to TCA good cause exception, please. I know we started having questions about this in the FIA hearing about, what are the times in which, as a policy, DHS is able to apply good cause exceptions for, non-cooperation with child support in particular. And I know we heard from you all a bit then and appreciate the commitment to really trying to address this in a more holistic way. I'm wondering so I think we saw in some of the information in the DLS report that, we know that you all have the flexibility of, instead of kind of writ large closing a case for non-cooperation, that you could instead choose to reduce the benefits by 25% for non-cooperation. Can you share a little bit more about, from a policy perspective, what are some of the circumstances that would lead you to cancel a case versus doing the reduction instead?
I can speak to that a little bit. Under the non-cooperation with child support and good cause, I just wanted to add that the Child Support Administration does not grant good cause. That is, good cause is granted by the Family Investment Administration. However, when a referral comes over to the Child Support Administration, we are required by regulation to proceed either with the establishment or the enforcement of support. If a parent raises an issue as maybe rape or incest as to reasons not to cooperate with child support, or if they're fearful because of retaliation or harm, then we report that to the Family Investment Administration, that this person or this parent does not feel that they should be cooperating with child support because of. Sometimes there's non-cooperation where they just don't turn in the paperwork or they don't come to their interview for their meetings. We are required to report that as well. The Family Investment Administration will meet with their client, because it's their client receiving the temporary cash assistance, to determine whether or not there is good cause for not cooperating with child support. One of the rules around non-cooperation also requires the parent to provide the name of the other parent, the non-custodial parent. If they indicate that they really just don't know who they are, we report that to the Family Investment Administration. If the if FIA does not agree with that parent, then there could be a reduction of 25% of the current grant. If they do grant good cause, they report that to the Child Support Administration, and we proceed with case closure. We will not pursue any further. But we only report the non-cooperation, and they grant the good cause or not. And if they don't give good cause, then they will reduce the 25%.
That's great. Thank you. I really appreciate the
You're
clarification.
welcome.
Thank you. Seeing no further questions from subcommittee members, I really appreciate DHS being here today. Please stick around for the advocates that are here to testify. We have just one, Staten Owens from AFSCME Local 112, or somebody from AFSCME. Yes? No? Are they here? Yes. Okay, thank you. Welcome. You may come down and testify. Thank you.
Good afternoon, Chairperson, Vice Chair, and members of the committee. Thank you for the opportunity to testify today. My name is Stanton Owens, and I work for the Anne Arundel County Office of Child Support. I'm here to urge you all to invest in Maryland's Child Support Administration. For many families in our state, child support is not an abstract policy issue. It's the difference between stability and crisis. It is how children get food on their tables, clothes for school, and the basic support that they deserve. Unfortunately, our offices are chronically understaffed and overwhelmed. As a team lead, I carry a caseload with a larger capacity than some of the agents that I currently supervise, while also then having to assist those employees with their own cases and questions. Families call our office frequently looking for help resolving issues that directly affect their ability to care for their children. Too often, we simply do not have the staff capacity to respond as quickly or as thoroughly as those families deserve. Where my office should have 4 team leads overseeing teams ranging from 3 and upwards, I am currently the only lead responsible for 6 agents of enforcement in my office. The workload is just not only heavy, but it's also unsustainable at this time. For every case that runs smoothly, there are several more that require time, investigation, and enforcement work that we struggle to keep up with. Investing in the Child Support Administration would allow us to hire and retain high-quality staff, reduce caseloads, and give each family the time and attention that their case requires. This investment is not just about improving our workplace, it directly impacts the well-being of children across Maryland. While child support cases stall because we lack the capacity to locate non-custodial parents or enforcement orders, families often have no choice but to rely on programs such as temporary cash assistance. Those costs fall on the state of Maryland in cases where we are unable to enforce the recoupment of said funds. In other words, underfunding child support does not save money, it shifts the cost to taxpayers and leaves families waiting for the support that they are legally owed. An investment in the Child Support Administration is an investment in Maryland's children, in working families, and in responsible stewardship for state resources. I respectfully ask that you support increased funding so that we can do the work Maryland families depend on us to do. Thank you for allowing me to speak today.
Thank you so much. We really appreciate your testimony. Do any subcommittee members have questions? Seeing none, appreciate you. Thank you. That concludes the hearing on the DHS Child Support Administration. We will do the Maryland Health Benefit Exchange next. Victoria Martinez, our DLS analyst, will come and share some thoughts on the proposed budget. Thank you.
Thank you, Madam Chair and members of the committee. My name is Victoria Martinez, and I'll be presenting the Maryland Health Benefit Exchange analysis. The Maryland Health Benefit Exchange provides a marketplace for individuals and small businesses to access affordable or no-cost health coverage. As you can see on the first page of the analysis, the allowance increases by $140.7 million, or 17%, for a total of $957 million. Exhibit 1 on page 4 provides an overview of the agency's spending. Most of the agency's budget, about 87%, goes towards reinsurance and state subsidy payments. The remainder of the budget includes 7% for information technology and 6% for administration expenses. And Exhibit 2 on page 5 shows the breakdown of these expenses. Exhibit 3, beginning on page 6, shows what is driving the $140.6 million increase. The largest changes are $79 million increase for payments in the reinsurance program and $40 million for the state subsidy program. There are also various increases to implement changes to Medicaid eligibility and enrollment that are required by the One Big Beautiful Bill Act, and this includes various increases for personnel, IT systems, call center, fulfillment notices, and marketing and outreach costs. In terms of personnel, that's discussed beginning on page 8, There are 12 new regular positions in the fiscal 2027 allowance, and all of these positions are to support the implementation of requirements from the One Big Beautiful Bill Act. MHB had a small vacancy rate of about 2%. Moving to the first key observation beginning on page 9, the first key observation is on federal changes impacting the marketplace. In addition to changes to Medicaid eligibility requirements, OBA and the CMS Marketplace Integrity Final Rule created significant changes in the marketplace. Changes include prohibiting financial assistance for households entering in the special enrollment period, pre-enrollment verification requirements that end auto renewals, the end of eligibility for financial assistance for many lawfully present immigrants, and the end of eligibility for enrollment in a health plan through the marketplace for DACA recipients. Moving on to the second key observation, beginning on page 10, this key observation is on the implementation of the state-based subsidy program due to the expiration of the enhanced premium tax credits. A premium tax credit assists eligible individuals with the cost of premiums for health insurance, and individuals are eligible with annual household incomes between 100% and 400% of the federal poverty level. The American Rescue Plan Act of 2021 enhanced these premiums by removing the 400% FPL cap on eligibility, and the Inflation Reduction Act of 2022 extended the enhanced tax credits until they expired at the end of calendar 2025. In addition to expanding eligibility, the enhancements of the premium tax credits also made premiums more generous by lowering the individual's required contributions to the cost of premiums. Exhibit 4 on page 11 shows the expected contributions for premiums, showing that individuals had the lowest contributions under the enhanced premium tax credits, and the highest contributions would have been at the end of the enhanced premium tax credits. However, the state implemented a state-based subsidy program at the beginning of calendar 2026 to mitigate some of the increases in expected contributions, making premiums more affordable. The subsidy program incorporated the Young Adult Subsidy Program, and Exhibit 5 on page 13 shows the enrollees in a qualified health plan by age. From 2025 to 2026, there was an increase in the population served by the Young Adult Subsidy, but there were decreases in enrollment in older populations. The end of the enhanced premium tax credits in part contributed to a significant increase in the cost of premiums. Exhibit 6 on page 14 shows sample monthly premiums, and Exhibit 7 on page 15 shows the average year-to-year premium change, showing an increase of about 13% in 2026. The increased cost of premiums could have also led individuals to choose more affordable plan levels with higher deductibles. Exhibit 8 on page 16 shows enrollment by metal plan, showing an increase in plans that are more affordable, but that offer lower levels of coverage. Exhibit 9 on page 18 shows that the implementation of the state subsidy program has mitigated some of the anticipated premium increases and enrollment losses. And in terms of the program's cost, a budget amendment added $52.3 million to cover subsidies for the second half of fiscal 2026, and this is in addition to the $26 million for the Young Adult Subsidy Program that was incorporated in the state subsidy program. The fiscal 2027 allowance includes $118 million to support the subsidy program, but since parameters for plan year 2027 have not been decided, DLS has asked MHB to discuss the estimated costs, how the estimated costs for fiscal 2027 were determined. The funding source for the program is the same source as the reinsurance program, which is supported by a 1% state provider fee assessment. Exhibit 10 on page 19 shows the closing fund balance, showing that the balance is anticipated to decrease significantly in 2026, with both programs drawing on that fund. So DLS has asked MHBE to discuss how it will ensure that the reinsurance program has sufficient funding while implementing the state subsidy program. The third key observation, beginning at the bottom of page 19, discusses the reinsurance program and forecasted funding. The reinsurance program was established in 2018 to address rising health insurance premiums, and MHPE receives federal pass-through funding to support the program. Exhibit 11 on page 20 shows the actual and estimated reinsurance costs and federal pass-through. Total costs in calendar 2024 were $71 million more than in 2023 and 6.8% higher than anticipated. The last key observation, beginning on page 21, discusses enrollment in a qualified health plan through the Maryland Health Connection. Exhibit 12 on page 22 shows that there was about a 15% increase in enrollment from 2024 to 2025. And page 23 discusses the DLS recommendation, which is to add narrative requesting a report on the reinsurance and state subsidy program costs and forecasts. And that concludes my presentation. I'm happy to take any questions.
Thank you, Ms. Martinez. Any questions from the subcommittee? Nope, seeing none. Thank you. We'll now invite our MHPE witnesses to join us. Ms. Eberly and team, welcome. Want to just take a minute to note that, sorry, my phone is transcribing my words. I apologize, that's confusing. Wanted to take a minute to thank you for your state service. 8 years and the MHPE is amazing, and we are very grateful for all of the great work you've done as you head into your retirement. So thank you for being with us today.
That has truly been my pleasure and honor, and I've had a great team behind me, which you know. So good afternoon, Madam Chair, Madam Vice Chair, and committee members. For the record, Michelle Eberly, Executive Director for Maryland Health Benefit Exchange. And with me here today is our Deputy Director, Johanna Fabian Marks, and our CFO, Tony Armiger. And I'd like to start by thanking Victoria for her work once again this year. We have a very complicated budget with all the ins and outs of where funds go. And Victoria always seems to get all the information, take it, make it really readable and presentable, and we're grateful that you're able to take all that data and get it all pleasantly put out for us, so thank you. Our team works very hard each year to use resources effectively and efficiently. This year, despite challenges from the loss of the enhanced federal premium tax credits and other federal reforms, we did have another successful year. Our 2025 annual report, which is linked in your testimony, highlights many accomplishments, several of which I'll briefly note today. Our AI password reset agent handled 43% of our reset calls in 2025. That deflected about 27,000 calls from live agents and saved us about $200,000 in our call center costs. Our AI enrollment status agent handled 8,600 calls in the first 2 weeks of our pilot program, expanding self-service and reducing call center workload. We anticipate that over the course of the next year, we will see close to $1 million savings in our call center costs. That's what we're hoping to achieve. We also launched our small business web portal to streamline enrollment and benefits management for Maryland small employers, employees, and brokers, including multi-carrier choice for employees. So we've been really striving to get this through a portal, and we finally did. And again, hoping to bring new cost savings to our small businesses and new opportunities to support their efforts in providing health care for their employees. All of our technology developments, and in fact all the work we do, is looked at through a lens of how can we improve our consumer experience, how can we reduce the administrative costs, and how can we better achieve outcomes. I did also include in the testimony, there's a link to our 2026 IT strategic roadmap, so you'll see what our plans are for technology for this year. It's such a large part of what we do. Also, Maryland again this year demonstrated its national leadership in health coverage affordability by establishing the Maryland Premium Assistance Program, ahead of the expiration of enhanced federal tax credits. That, combined with the state reinsurance program, helped drive a 3% enrollment growth for 2026 coverage, ranking us number 3 nationally and making Maryland one of only 8 states with open enrollment growth this year. Targeted outreach also provided effective with our enrollment efforts. We had enrollments increase 7% among our young adults, 4% among our Black consumers, and another 2% among our Hispanic consumers. However, and this is the big however in this year's open enrollment, it requires us to look a little bit deeper this year. Although we had that 3% growth in open enrollment, we also saw a lot of what we refer to as buy down of coverage. So our open enrollment this year told us one thing. It told us that Marylanders really want health coverage, and they will do what they need to do to keep their health coverage. Unfortunately, for many, that included increasing their medical liability risk from a $1,000 gold deductible by buying down to a bronze plan, which carries a $10,000 deductible. And in fact, 31% of those were over age 55, and 43% earned over 400% of the federal poverty level, which for an individual is $60,000 gross income. So figure taking on a $10,000 medical liability risk with earning $60,000 gross for yourself. And that is part of the story. We are also looking at what we'll see in continuing disenrollments as the year goes on. So one of the things with health insurance and in Maryland, even if you aren't eligible for any tax credits, you have a 31-day grace period to make your payment of your premium before you're terminated. If you do receive any tax credits, that's extended to a 90-day grace period. So we don't expect we're going to know the true story of who's not continuing their coverage probably until the 1st of April because of those grace periods. And as with most insurance, you can do nothing, and if you don't pay your bill, you'll be terminated. Now, in those continued losses, what we know our consumers are struggling with is obviously the cost of increase in costs in rents, in food, in gas, and electricity. And so we also know, and this is the controller had told us, that many Marylanders don't have a lot of savings that they have to fall back on. So one, failure of a car, one unexpected issue can make people have to make really tough choices. And oftentimes, if people are feeling healthy, they'll say, well, I can let my health insurance go. So that's a concern. We did see in January our change year over year from terminations was 6%, but in February, and these are preliminary numbers for February, it jumped to 57%. So that's something we're going to track very closely and see. And of course, the number one reason we categorize why people are not continuing their insurance, and obviously the number one reason is that it's not affordable anymore. So that's a big difference. Let's see, what else did I want to share with you before I turn it over to Johanna? I think that was all for what I wanted to speak about. I'm going to turn over to Johanna to address the State Premium Assistance Program, Reinsurance Program, and address the specific questions posed in the analysis.
Thanks, Michelle. So briefly, on page 18 of our report, DLS asked that MHBE discuss how the estimated costs for fiscal 2027 for the State Premium Assistance Program were determined, given that the parameters have not yet been established for plan year 2027. And that's a good question because, as noted, our board sets those program parameters annually, so they're set each summer for the following calendar year. So this past summer in August, the board set the premium assistance parameters for calendar year 26. This summer, they'll set them for calendar year 27, which is obviously part of FY 27. However, in order to develop our estimated cost for FY 27, We relied on modeling that we did last summer when the board was setting those calendar year 26 parameters. At that point, we modeled several out years, showing our board several different options for how they might continue the subsidy in future years. We anticipated at that time, and still do, that we won't have sufficient funding to offer the same level of generosity in calendar year 27 as we're doing in this current year. So we wanted to give the board a sense of what those less generous subsidies might look like. And we chose one of those scenarios, which seemed like a potential opportunity for calendar year 27 when forecasting the costs that went into the FY27 estimate. We will have those actual parameters set this summer, and we will be doing significant additional modeling between now and July to better inform the board as they make those projections and set the parameters. The second question, also on page 18, DLS mentioned that MHB should discuss how it will ensure that the reinsurance program has sufficient funding to meet obligations while implementing the state subsidy program. And this is a very important question to us, one that I spend a lot of time on weekly, monitoring what our spending is under the state subsidy program and how that impacts the reinsurance program overall, because they use the same funding source. We are committed to ensuring the solvency of the reinsurance program. We have a commitment to the federal government under the parameters of our waiver to maintain that program through the end of 2028 and provide state funds to draw down the federal match that supports the program. Our board has several tools to control the cost of the subsidy program to ensure that we do keep the reinsurance program solvent. Those include, as I mentioned, modifying the parameters to make the program less generous next calendar year, and also considering closing the subsidy program to new enrollees this calendar year who would enroll through special enrollment periods. So the board will be monitoring the projections along with staff and considering which of those tools are necessary as we go forward. Thank you.
Thank you so much for your testimony. We really appreciate it. Do members of the subcommittee want to ask any questions? I have some. Sure, I'll go first. So I want to talk a bit about enrollment in qualified health plans by age and metal plans. So on page 13 of Exhibit 5 in the DLS analysis, enrollment for a qualified health plan decreased by 2%, or nearly 20,000 people for the 55 to 64 age group, and enrollment decreased by 6%, or nearly 60,000 people for 65 and older age group. Perhaps that's maybe a Medicare related number, but I'm not certain. Could you elaborate on what state level or federal level changes have impacted enrollment in qualified health plans, and what outreach efforts MHPE has used to focus enrollment for people 55 and older?
Absolutely. And this did come out, we had three things that happened last year. Of course, there was a final, the program integrity rule that came out, and then after that was the OBA, and then, of course, the enhanced premiums that were eliminated. So the first thing that happened was for our DACA recipients, we had to terminate coverage for any DACA recipients. We had about 300 the end of September. So they lost their coverage. We could not enroll any more. The other thing that was effective 1/1/26, for their under 100% FPL, we have lawfully present immigrants that could use the tax credits, and that we had to stop. And there is a lot in that category that are over the age of 65. So a lot of folks that have not worked in the system long enough to get Medicare. That was one population, but then also the population that are here lawfully present, but they could not utilize those tax credits. So we saw a significant loss there. The other issue that came out of OBA was, well, the fact that they did not extend the premium tax credits. And so that cliff, what we used to talk about, the cliff at the 400%, where before those increases through ARPA where they allowed people to collect tax credits if they were over that 400% of FPL. That stopped. So we went back to the cliff where there was no federal tax credit for that population. And that, again, that's an individual, it's 60,000, a family of four, it's 128,400, I think. The other impact there was, as Johanna was talking about, for the state premium assistance program, we did not have the funds to keep the program solvent, the reinsurance program solvent, which is where we're taking those funds from, and to offer a subsidy to those over 400%. So there was no additional, and that's where we saw the significant loss, particularly in those over age 55, and also the over 400%, as I mentioned. Miss anything? Okay. Oh, outreach you asked about. We started a year ago, June, particularly with the DACA recipients, saying, you're losing coverage, you will be losing your coverage. If you need services, get them now before you lose your coverage. We also started communicating in general to our general population that premiums would be going up. Some people may not be able to access coverage or afford coverage, so again, be thoughtful about using the coverage you have this year while you have it. So we did a lot of that. We did texting, we did emails, we did social media. And in fact, feedback we got from the field was that some of our navigators heard that, particularly on those where we were able to do the subsidy, the premium wrap or the premium assistance program, that they were shocked that they had expected, because of all the communication, that they would probably have a big challenge. And the feedback was, wow, it's not as bad as I thought it was. But again, those were for the folks we're able to support.
Okay, got it. Thank you. I really appreciate that feedback and answer. Madam Vice Chair.
Get my button on here. Hi. Thank you so much for being with us. I had a question about vacancies, and the governor's allowance includes $1.4 million for 12 new positions to implement the requirements of HR 1. How exactly will those individuals do that? And could you discuss the 12 new positions as it pertains to the vacancies?
Absolutely. This is all required to Medicaid work requirements. So this is all OBA related, those 9 positions. 3 of them are for IT to support our, 3 of them are for IT to support IT efforts, and the other 9 are for our consumer assistance. So we have, I think there's 3 for escalated case resolution, 3 appeals, and 3 constituent services. So those were those 3. For the work requirements, 2 things are happening. One, we now have to verify twice a year that someone's eligible for Medicaid, and that's for a population of about 320,000 people. Those are the ACA expansion. And then now we're going to have to run them through a lot more criteria for work requirements or volunteer efforts. So we know that we're going to need more these positions to help with people that are having problems with that. And
Right, so we need to hire 12 new positions in order to understand twice a year or know the eligibility, correct?
That is correct.
And just really quickly, all of the other hurdles that HR 1 imposes on the eligibility, how much time do you all think that will take for one person's case, like on average?
It's hard to know right now. I mean, we took what we know what we get in appeals for Medicaid. We have, at the exchange right now, we have limited staff that do all the appeals and all the constituent services. And remember, that's, 1 million Medicaid, 1.1 million Medicaid enrollees, and then our 250,000 QHP enrollees. So the intent is for us not to hire all these at one time. We will hire 3 and then see what the needs are, and then hire more, and then hire more. So we don't know what it's going to produce. And when we did put in, we put in numbers for the governor's office, and they came back and said, really just prioritize what you absolutely have to have. And so we really shrunk it down to say, this is what we believe we actually have to have. But we'll
So
monitor
this is,
that.
I apologize.
Yeah.
I just want to stop you. You're saying this is, without a doubt, you have to have these 12 positions, and this is after you boiled it down?
Correct. You want to, were you have more heavily involved, or Tony? Because we did go through math calculations of, this is how many appeals we get today on this population. What do we expect that we'll get for calls, for appeals, for all the work we have to do in constituent services? This is just in constituent services. And that's where we came up with that number. However, our intent is not to hire them all right away because we don't know. But that's what's been allocated to us in this budget. And Tony or Johanna, if you have anything more to add to that, feel free.
No, I don't.
Well, thank you so very much. I appreciate that.
One moment, please. Oh, I'm sorry. This one's not. One moment, please.
I was so excited and wanting to dive into HR1 that the green got me, sorry. The Irish got a hold of me. I want to skip over onto page 10 of the analysis. Approximately 20,000 lawfully present individuals older than 65 are disallowed from receiving premium tax credits, and another 20,000 lawfully present immigrants have been barred from financial assistance. So even if lawfully present immigrants can enroll in qualified health plan through Maryland Health Connection, will they be able to afford their coverage?
Would you like to take this one?
Sure, yes. So, yes, as you mentioned, there's two tranches of 20,000 individuals. The first changes hit this January 1st. Not all of those are over 65, but many are. And that's similar for the next group of 20,000 who will be impacted January 1, 27. The group impacted this year are all individuals below 100% of the federal poverty level. They're ineligible for Medicaid because of their immigration status, but it's unlikely that many of them would be able to afford to pay the full price of health insurance on the marketplace.
Well, my next question is, where will those lawfully present immigrants go to receive care if they will not be enrolled in a qualified health plan through Maryland Health Connection?
And this is a real challenge, and we've been talking with our stakeholders. Many go to the federally qualified health centers, but their funding's being cut. We're finding that, especially in the Hispanic community, there's a lot of fear to even go get coverage. So they're refraining from getting coverage. We know that things will get bad and they'll just go to the emergency room when they have to go, or they'll self-pay by going to urgent care centers. But we're, in talking to all of our stakeholders, the immigrant community is really concerned about how they access care. And those of us that have been able to offer care outside of the exchange are concerned about funding to be able to continue to do so. So it's a really difficult position to be in for our immigrants.
Absolutely, it feels like a public health emergency waiting to happen. So equally concerning on page 10 of the analysis notes that approximately 300 DACA recipients were de-enrolled or disenrolled from qualified health plan through the state's health insurance marketplace. So what other options are there, if any, for DACA recipients to access health care?
It's the same story. I mean, they're not able to get, well, they're not even able to purchase on the exchange. They could go off exchange. Yeah, they could go off exchange and purchase, but they would not get any tax credits, any young adult, and many of the DACAs would fall in that young adult category. So they can't get any of the young adult subsidies, the premium state assistance, none of that. So they could go purchase direct from a carrier, but again, is it cost prohibitive?
So for all those watching at home and on the record, that means that anything that they would purchase would be exorbitantly expensive.
Well.
and higher than what they would get
in Maryland-
previously.
In Maryland, we're very fortunate that the reinsurance program still allows us to have lower rates compared to the rest of the nation. But again, it's juggling your rent, your car payment, all of those issues. And now you have to full pay for your health coverage.
Thank you.
Thank you, Madam Vice Chair. I think that concludes our questions for this panel. Thank you so much for being here today. We have no public witnesses signed up for this specific budget, so that concludes our budget hearing on the Maryland Health Benefit Exchange. We will conclude today with the Department of Human Services Office of Home Energy Programs. So I'd like to invite Suvaksha Bujel to join us for her presentation of the DLS analysis. Thank you.
Thank you, Madam Chair. For the record, Suvaksha Bujel here to discuss the Office of Home Energy Programs. The operating budget for the Office of Home Energy Program, or OHEB, decreases by 0.7 million or 0.3% to a total of 300.9 million in fiscal 27. We will start with MFR data. Exhibit 1 on page 4 shows vulnerable populations receiving energy assistance benefits. The percentage of households with a member over age 60 and households with an individual with a disability receiving benefits increased in fiscal 25. However, the percentage of households with a child under age 6 decreased. We are asking DHS to comment on the reasons for this decrease and its efforts to increase the participation rate. Previously, DHS has also included in annual MFR submission a measure of overall participation rate in the benefit programs, comparing the numbers participated to estimated eligible population. Fiscal 27 submission did not include general participation rate. DLS recommends adopting committee narrative requesting data on vulnerable populations and general participation rate measures for energy assistance benefits. As shown in Exhibit 2 on page 6, in federal fiscal 2024, the average annual energy burden after receiving low-income home energy program or LIHEAP benefits was lower for both all households and high energy burden households compared to federal fiscal 2023. Exhibit 3 on page 7 shows the benefit targeting index, which focuses on the extent to which the highest benefits are paid to those with the highest energy burden. This has decreased each year since fiscal 2020. The benefit targeting index of 98 in federal fiscal 2024 indicates that households with the highest energy burden saw a 2% lower benefit compared to all households. Moving on to page 8 is the federal shutdown impacts. Due to the federal government shutdown, LIHEAP allocation for federal fiscal 2026 was delayed. As a result, under the state of emergency that was declared in Maryland in October 2025, the use of Strategic Energy Investment Fund to support Maryland Energy Assistance Program for November was authorized. Moving on to the proposed deficiency, the budget contains deficiency appropriation totaling 3.9 million. 2.4 million is in special fund and 1.5 million in federal funds. The proposed deficiency appropriation includes realignment of 22.5 million from the LIHEAP grant for MEP benefits that was labeled as call center in error in fiscal 2026 budget. Exhibit 4 on page 9 is the overview of agency spending. 280.8 million or 94% of the OHIP budget supports energy assistance benefits. Funding for Electric Universal Service Program benefits, or USP, totals 197.8 million or 66% of the budget. The funding level for USP program varies primarily with the availability of CEF revenues allocated by statute for energy assistance. Funding for MEP energy assistance program assistance benefits accounts for 82.6 million or 28% of the budget. Exhibit 5 on page 10 is the proposed budget change chart. Fiscal 27 allowance for OHIP decreases by 0.7 million compared to fiscal 26 working appropriation after accounting for proposed deficiency appropriations. This decrease is primarily associated with a decrease of 1 million associated with local administering agencies and a decrease of 0.4 million associated with personnel expenses. Total federal LIHEAP funding included in fiscal 27 allowance, including both funding for energy assistance and program administrative costs, total 94.7 million, of which 82.6 million are budgeted for energy assistance. The annual amount of USP ratepayer surcharge revenue collection is set at 37 million. Including funding for both energy assistance benefits and program administration, 50.2 million is budgeted in fiscal 27 allowance, approximately 13.2 million more than the annual maximum collection amount. Including the deficiency appropriation of 9.8 million, USP ratepayer surcharge revenue totals 58.7 million in fiscal 26. Although deficiency appropriation increased the amount of funds over the limit in fiscal 27, the budgeted amount exceeded the maximum collection amount prior to the deficiency appropriation by 11.9 million. DHS reports that the funds in excess of the maximum collection amount was an error, and it will ensure that USP funds are not overspent. DHS also reports that the funds in excess of the 37 million will be provided through SEEF and funds available from a Public Service Commission order related to electric generating facility at Dominion Cove Point. In the analysis for DHS administration, DLS has recommended reducing EUSP funds for call centers, 3.4 million in fiscal 27 and 7.5 million provided through deficiency appropriation in fiscal 26. If adopted, these recommendations would reduce the amount of USP revenue budgeted. However, it would still be over the maximum collection amount in both fiscal years. As shown in Exhibit 6 on page 11, USP used for administrative purposes has increased in recent years. Particularly in fiscal 26 and 27, the amount of USP revenues set aside for DHS administration and OHIP expenditures not associated with assistance increased significantly. DHS should discuss its efforts to ensure correct funds are used to cover the expenditure and how funds from DCP are available to replace USP revenues, since fiscal 27 allowance already budgets the annual contribution of $400,000 for energy assistance. DHS should also discuss the growth in administrative spending from these funds in recent budgets. Next discussion covers the Strategic Energy Investment Fund. As shown in Exhibit 7 on page 14, revenues have grown substantially in recent years due to increases in regional greenhouse gas initiative auction clearing prices. Total RESI program revenues received by Maryland from all auction held during fiscal 25 total $267.5 million. Exhibit 8 on page 16 provides a historical summary of the annual levels of SEEF funds budgeted for energy assistance through OHIP. Fiscal 27 allowance includes $160 million in SEEF funds. The anticipated closing balance of energy assistance sub-account of SEEF is $52.8 million in fiscal 27. If DHS uses SEEF to cover all expenditures budgeted from USP ratepayer surcharge revenue in error in both fiscal 26 and 27, the anticipated closing balance will be $31.7 million in fiscal 26 and $18.5 million in fiscal 27. DLS notes that the funds in energy assistance sub-account of SEEF are only authorized to support energy assistance. DHS should comment on how much of the expenditures that were budgeted from USP ratepayer surcharge revenue in error will be covered by SEEF. Given that some of the USP overages are associated with administrative expenses, DHS should comment on how it intends to cover those expenses. On page 18, we have the personnel data. The number of positions in OHIP decreases by 2 in fiscal 27, of which 1 position is internally transferred within DHS and 1 position is closed. Given that a position is closed in OHIP and total positions in DHS overall remains unchanged, DHS should comment on if and where this new authorized position is in fiscal 27. Starting on page 19 is the issues section. The first issue covers energy assistance applications in fiscal 25. As shown in Exhibit 10, total applications for energy assistance benefits have fluctuated in recent years. In fiscal 25, the number of applications for energy assistance decreased by 31.2% compared to fiscal 24. DHS reports that this decrease is associated with improvements in data reporting. DHS updated its system to detect and remove duplicate or incomplete applications in fiscal 2025. Although the number of applications received in fiscal 25 declined, the number of households receiving benefits has increased. Between fiscal 2020 and 2025, the number of households receiving energy assistance benefits increased among all benefit types. The increase in households receiving MEP and gas arrearage assistance in fiscal 25 is primarily due to OHIP pausing issuance of benefits in fiscal 2024. In April of 2024, funding for certain programs were exhausted and DHS stopped issuing new benefits under the program, therefore decreasing the recipients for these programs. In fiscal 2025, the benefit amounts were reduced for the bill payment program to accommodate the anticipated increase in number of eligible households. However, even with the increased number of recipients, benefit expenditures were lower than expected. As a result, OHIP issued supplemental benefits at the end of the year for USB bill assistance and MEP. Exhibit 11 on page 21 shows the supplemental benefit, which ranged from $150 to $400. Exhibit 12 on page 22 compares average MEP and USB payment in fiscal 2025 before and after supplemental benefits. Exhibit 13 on page 23 shows the average benefit size for both bill payment assistance program in fiscal 2025. The average benefit size decreased compared to fiscal 2024. Each year, OHIP examines expected number of applications and recipients and adjusts benefit level based on estimated available funding and recipient labels. As the estimated number of eligible households decreased, OHIP increased the benefit amount in fiscal 26 for bill payment programs. However, the increased benefit amount is lower than the benefit provided in fiscal 2025 after accounting for the supplemental benefits. Exhibit 14 on page 24 shows energy assistance applications and benefit data. Through December 2025, fiscal 26 applications for all energy assistance except for crisis benefit program has increased compared to application during the same period in fiscal 2025. The increases indicate continued high demand for energy assistance as energy prices have continued to increase through the first half of fiscal year. DHS should comment on if it has seen additional recent growth in applications. Consistent with the higher number of applications, the number of households receiving energy benefit has also increased for all programs, except for the USB arrearage assistance program. Households are eligible to receive arrearage assistance once every 5 years. This limitation on eligibility for this program results in higher rates of denial as well as fluctuation in the number of households receiving benefit each year. Total benefit paid in fiscal 26 through December has increased by $33.9 million or 68.4% compared to benefits paid during the same time period in fiscal 25. This increase is primarily due to the benefits paid through December 2024 not accounting for the supplemental benefit that was provided later in the fiscal year. Language in fiscal 26 budget bill restricted funds pending submission of a report on application denial rates. DHS has submitted the report and issues 2 and 3 cover information provided in the report. As shown in Exhibit 15 on page 26, application denial rates in fiscal '24 for all benefit types were the highest since at least fiscal 2014. DHS notes that the substantial increase in denial rates in fiscal '24 is associated with implementation of categorical eligibility that began in that year. Denial rates have decreased for all benefit types during fiscal 2026 as of November 1st, 2025, compared to fiscal '25. Exhibit 16 on page 28 shows the most common reasons for application denials. The third issue covers energy assistance application processing times. As shown in Exhibit 17 on page 29, in fiscal '26, the statewide average number of days to process an application was 25 days. Exhibit 18 on page 31 shows application processed beyond the 55-day guideline. In fiscal '26, 7.9% of applications statewide have been processed in longer than 55 days. 4 LAs had over 20% of applications processed beyond 55-day guideline. We are asking DHS to comment on the reason for high percentage of applications being processed beyond the 55 days. DLS determined the information provided complies with the language restricting the special funds and therefore recommends the release of $250,000 in withhold funds. DLS will process a letter to this effect if no objections are raised by the committees during the budget hearing. DLS also recommends restricting funds pending submission of a report on energy assistance application processing times and denial rates. Starting on page 33 is the recommended actions. The first recommendation is to reduce general funds for personnel expenses. Administrative costs for OHIP are supported with special and federal funds. Second recommendation is a language withholding funds until a report is submitted providing fiscal '26 and '27 year-to-date data on application processing times and denial rates. The third recommendation is a committee narrative requesting fiscal '26 MFR data. This concludes my presentation, and I'll take any questions you may have.
Thank you so much for your thorough and thoughtful analysis. Do any subcommittee members have questions for our DLS analyst? Seeing none, thank you. We'll call up our DHS team, please, to join us at the table, and we will review your agency responses to the DLS issues highlighted. Thank you.
Good afternoon again. I'm Gloria Brown-Burnett, Interim Secretary for the Department of Human Services. I want to acknowledge the team here with me today, including our CFO, Roman Napoli, and Courtney Thomas Winterberg, who is the director, DSS director in Allegheny. But it formerly helped us to lead and clean up energy assistance, and our director, who I would have loved for you to have met, Ryja Moore, is fulfilling her civic obligation and is doing jury duty. Our home energy programs help Marylanders with utility arrearages and their bills in two ways. The Energy Assistance Program, MEAP, Maryland Energy Assistance Program, MEAP, helps with home heating bills using federal funds, and the Electronic Universal Service Program, EUSP, which helps with electric bills through the Maryland Strategic Energy Investment Fund, SEEP. Starting last July, Marylanders can apply for all home energy programs as well as other critical benefits at the same time through the Maryland Benefits One application. In 2025, we have served Marylanders by moving quickly after May 2025 Western Maryland flooding to provide $1 million in emergency relief funds to replace damaged water heaters and heating and cooling systems. We reduced statewide application processing times by 25 days after shifting to the Maryland Benefits One application and other application process improvements. We implemented our automatic enrollment of eligible customers in our joint weatherization program with the Department of Housing and Community Development. and improved our fiscal oversight by monitoring real-time benefit expenditures and funding allocations to local administering agencies. In 2026, we continue to work to lower energy costs and expand energy assistance benefit access to Marylanders. We are piloting a community solar program and expanding access to alternative energy sources, and we are rapidly prototyping and deploying technology improvements in our call center and our back office processes to help us more efficiently and accurately cut red tape and minimize disruptions. For more information, we provided more details in our written briefing. I will now turn it over to Roman to respond to the DLS prompts.
Yeah, thanks. On page 4, we were asked to comment on reasons for the decrease in participation among households with a child under 6. In 2025, we updated our managing for results methodology to refine the reporting logic. In parallel, we updated historical data for 2024, but not prior years due to reporting challenges with our data system going that far back. As a result, 2023 and 2025 figures are not directly comparable. We believe there's not been an actual decrease in participation. We concur with DLS's recommendation on page 5 to adopt the committee narrative. We were asked to comment on page 12 on how we ensure that funds are used to cover the expenditures and how funds from DNCP are available to replace the EUSP revenue. DHS submits an annual EUSP operational plan to the Public Service Commission, which outlines the planned use of DCP, EUSP, ratepayer, and C funding to administer electric bill payment and arrearage benefits. The Commission approved the plan based on an available statutory funding for EUSP ratepayer $37 million, $400,000 for DCP, and the 2026 CEF appropriation at $150 million. The governor's allowance reduces the EUSP ratepayer allocation to in 2027 by $700,000. The additional 2027 $12.7 million in revenues was assigned to EUSP in error. The 2026 local administrating agencies received a 5% increase in funding for program operations, the first increase in 4 years. This program operations funding has been realigned to the governor's allowance. The cost share, previously 40% state funds, 60% federal, transitioned to a 50-50 split in 2025. The realignment was driven by a number of households served by each program and funding availability. On the DLS request on page 16 to discuss expenditures that were budgeted from EUSP ratepayer surcharge in error, an additional $500,000 was budgeted for EUSP in error, and an additional $200,000 was subtracted for outreach funding. The total amount of $700,000 will need to be charged to the 2027 CEF allocation instead of where it is now. On the DLS request on page 18 regarding staffing levels within OHEP, as we discussed in our other budget hearings, the reduction in PINs is due to a cleanup of DHS worldwide personnel data, not a reduction in the OHEP team size. The specific PIN that was referenced as being frozen is now actively being recruited for, and we hope to fill it in the first half of 2026. With this, I'll turn it over to Courtney.
On whether OHEP has seen an additional growth in applications referenced on page 23 of the DLS analysis, the growth in applications has remained relatively consistent with the trends cited in the DLS analysis. Through January 31st, 2026, unduplicated applications have increased by 23.37% when comparing fiscal year 25 to fiscal year 26 year to date. On the reasons for processing applications beyond 55 days in Caroline County, Montgomery County, Southern Maryland, and Howard County, we continue to closely monitor processing times, and performance has improved significantly over the past 3 fiscal years. Overall, the percentage of applications processed beyond 55 days has decreased from 29% in fiscal year 24 to 12.5% in fiscal year 25, and further to 7.9.1% as of November. With respect to the 4 named jurisdictions, in Caroline County, we have helped with restructuring internal workflows, eliminating outdated practices, and implementing strengthened case tracking and career management protocols. Caroline County has also reassigned additional staff to reduce the backload and is using mass certification to expedite case approvals. We believe Caroline County is moving in the right direction with these corrective actions, and the state OHEP team will continue to support them throughout fiscal year 26. Montgomery County has seen a 25% year-to-date increase in applications between fiscal year '25 and fiscal year '26, while simultaneously reducing their application backlog by 11.9%. We continue to work with county staff to help improve their back office operations. Southern Maryland, which serves 3 jurisdictions, has faced significant staffing and leadership challenges this fiscal year due to employees being out on extended leave. As of November 1st, 2025, 24.5% of their applications exceeded 55 days. We continue to work with them on a biweekly basis. Howard County has made notable progress through targeted training and process modernization efforts, reducing their application processing days of over 55 days by 16.6 percentage points compared to fiscal year '25. In relation to the DLS recommendation to release the $250,000 withheld in special funds noted on page 32, we concur. We also concur with the DLS recommendation on page 32 to restrict funding pending submission of a report on energy assistance application processing times and denial rates. In response to DLS operating recommended actions beginning on page 33 of the DLS analysis, we concur with the reduction of the $46,229 in personnel expenses. We concur with the request on OHEP application data, but ask for a submission date of January 31st, 2026 in order to analyze and validate the data. And we concur with the managing for results request for participation rates in fiscal year '26.
Okay, thank you so much, DHS team, for your response. Recognizing Delegate Stanko for a question.
Thanks, Madam Chair. I just want to get some clarification from my own understanding of the process with regards to the, I guess it's called the Energy Burden Index, and the goals to get to over 100. First off, I want to commend you on the work that's been done, but also process and also the automatic enrollment piece you just rattled off, like Caroline County and Howard County and some different places. So if I'm understanding this right, so first just a qualifying question. So if I'm understanding this right, some of the things that are being done manual are going to be moved into an automatic qualification, correct?
That's correct. Categorical eligibility was implemented January 1 of 2024. We wrote it out without having all of the system enhancements in place that really helped to expedite the processing. Most of those system enhancements were put in place in fiscal year '25, and it has greatly reduced the processing times significantly across the state. But there's been some tremendous gains, particularly with Baltimore City. They had one of our lowest processing times in fiscal year '25 and continue to have lower processing times in fiscal year '26.
Okay, thanks. What happened, was there any change in PINs for that, or was it just that you were able to get to the volume faster?
So a lot of it was just the categorical eligibility process, because the customers that are approved for SNAP or cash benefits are automatically qualified for OHEP as long as they meet the other criteria. So on the family investment side, they've already validated the income as well as the citizenship piece. So it's a matter of making sure that we have the utility information to be able to process their OHEP benefits.
Okay, so it's more technical than it is
Yes.
Anything else. Okay, I appreciate that. And then just as a quick follow-up to that as well, as you move, or as you kind of continue to move forward and work on the changes with the automatic enrollment, or that's finalized, so to speak. I guess mine's more of a process concern, but I think about the budget. It's also my understanding we're moving to a model that's going to be, or we've started the process and we're fully implementing the model to where there's going to be high energy demand users and then also the poorest users, and that model works together. Is there any concern around that? Like, what I'll say is, like, if we think of the poorest and the highest burden as being tier 1, just for this purpose of this conversation, where you have the poorest, but they don't have they just don't have the same demand because they're more conservative with their use more than anything else, that they get left behind under that model.
So in fiscal year '25, we revised the benefit matrix methodology, which does target the highest benefit to those with the greatest energy burden, so the lowest income with the highest usage. With the EUSP calculation, it is a tiered benefit even beyond that based on usage. So someone that's using 12,000 kilowatts of electric each year, their benefit will be higher than those that are using 1,500 in that same category, even if they're the same percentage of poverty. Again, I can't say it's a science. It's very much a work in progress. There's a couple of other things that are coming into play, though, that we really hope will reduce the energy burden for a lot of the families that we serve, and that's PC 59 that the Public Service Commission is rolling out in January of 2027. OHEP is an active participant in that OHEP will be doing all of the income eligibility verification for the utilities to apply that additional credit. So they will qualify not only for energy assistance benefits, but then also that reduction from the utilities.
Okay, and my last question, Madam Chair, is and just as a follow-up to that, is I guess one of the concerns that I always think about, both from a policy perspective, but then the budget specifically, is that it's kind of that incentive alignment, right? Like, I think the concern that I would run into is that you have we as a state have someone that falls into a tier where they meet the poverty burden, right? So we're assuming the poverty burden. But even because of that poverty, like, maybe they know about this program, but they're literally counting pennies to, like, every penny that they can save. And so it's like, turn the heat down, keep the lights off, right? And then we're rewarding someone that's not doing that, right? And more particularly, as a budgetary perspective, if we are thinking about that from a policy perspective correctly. So I just like, have we had a scenario, just a question, have we had a scenario where there's people that we've said, these people really are eligible, but the budget appropriations is not there to provide it to them?
So I think that's one of the reasons we realigned the benefits in fiscal year 25 and fiscal year 24. We had not adjusted the benefits to serve more Marylanders, which is why we exhausted benefits in April of 2024. In terms of that scenario, the only benefit that actually utilizes the usage calculation in addition to the poverty is that for EUSP, and in fiscal year 25, it was also capped at that
Right.
13,000 kilowatt usage hours. So on the MEEP side, and then the arrearage, it really is based on their benefit level, which is driven by the percentage of federal poverty.
Okay, thank you.
Thank you, Delegate. Thank you, DHS team. I want to ask a question about energy assistance application denial rates, please. So on Exhibit 16, page 28 of the analysis, the most common reason for denial of an energy assistance application was due to the application having incomplete information. I know there's like a maybe 3-month period to cure. I think DLS noted, if I'm remembering the number correctly. What outreach does OHEP or the local social service agencies that are processing these applications do to ensure that applicants are notified of what information is required to submit?
So when a customer submits an OHEP application that is not complete, they receive a request for additional information form that lists on that form exactly what they need to provide. If they do not provide that information within the time frame, then they receive a denial notice with the information related to that 90-day curing period. Again, stating what they would need to do to submit their application to have it cured and processed. Even outside that 90 days, however, if someone would come back and apply again, if they were previously denied, those local agencies will continue to process the applications.
Okay, got it. And so once somebody receives the application denial letter or that they need more information submitted, are they only getting outreach just one time via letter or email, or are they getting more outreach?
I think it really depends on the local administering agency and the volume of applications that they have coming in.
But at a minimum, they get that first letter, and then they get the denial letter with the information about what they need to turn in, and they have those 90 days to cure, so.
Okay, got it. Okay, thank you. I appreciate that information. Seeing no further questions from the subcommittee members, I want to thank the department for being here today. We don't have any public witnesses signed up today, so that concludes the budget hearing for OHEP, and it actually concludes all of our subcommittee budget hearings. So you guys we saved you for last. Congratulations, everyone, and thank you so much. We'll see you soon.